Good morning, ladies and gentlemen. Thank you for attending our first Managed Care Oversight Committee meeting for this year. I would like to say thank you to the senators and representatives for making time today on a Friday, on a beautiful sunny day, to come in and be a part of this meeting so that we can continue our process and our work in state government. I do want to just make alert to the lobby that my style of running a meeting will be that we will not be running behind schedule. We may be running on schedule or ahead of schedule. So if your members that aren't in the room that are going to be speaking, you'll want to get them here soon because we will run ahead if indeed the schedule allows us to do that. But we won't be running behind. With that, I would ask that LSA would call the roll.
Senator Monique.
Here.
Representative Fry.
Present.
Senator Costello.
He's on the phone.
Senator Mathis. Here. Senator Reagan.
Here.
Senator Segenhart.
Here.
Representative Brown Powers.
Here.
Representative Forbes.
Here.
Representative Lundgren.
Here.
Representative Meyer.
Here.
Thank you, Patty. Would also like to welcome some new committee members. Representative Brown Powers, you're new to the committee. Representative Meyer, you're new to the committee. And I believe Senator Miller Meeks, you're new to the committee. So thank you for saying yes and joining us. So I'd also like to recognize Representative Forbes, who is the new ranking member on the HHS budget. We're glad to have you as a part of that and look forward to working with you this next year. With that being said, we're going to continue to move right on into the agenda. And our first presentation will be dealing with the United Transition, Director Randol and Director Claybaugh. If you please join us at the table. I believe there's a microphone at the end for each of you. And with that, the floor is yours. Members, we will take questions at the end of each one of the presentations as long as time allows. So we'll turn it over to whichever one of you are going to start.
Okay. Thank you very much, Senator Miller Meeks, Representative Fry, members of the committee. Thank you very much for the opportunity to speak with you today. I'm Garrett Claybaugh. I'm Interim Director of the Iowa Department of Human Services, and again, Director Randall and I are pleased to be with you today. My comments are just very brief this morning, and I wanted to just acknowledge Governor Reynolds' recent appointment of Kelly Garcia as the Permanent Director for the Department of Human Services. I know you're aware of that appointment. Ms. Garcia is currently Deputy Executive Commissioner of the Texas Health and Human Services Commission. She oversees 40 client services programs and support functions. As Deputy Chief Program and Services Officer for the Texas Commission, her responsibilities included oversight of Medicaid, eligibility operations, and behavioral and mental health in Texas. She's scheduled to begin her work at the department on November 1st, so we're looking forward to that. Thank you again for this opportunity to be with you today, and I'll turn it over to Director Randall for our presentation.
Good morning. Thank you for the opportunity. I appreciate the chance to provide you an update on United Healthcare transition and some other agenda items that you've requested that I provide an update. I'll start by going over the transition. There are several handouts as I go through my presentation that I'll call those out and identify those for you, and we can walk through those as well. As you know, United Healthcare left Medicaid on June 30th, and Iowa Total Care joined July 1st. As I stated before, we learned from the exit of AmeriHealth very valuable lessons with respect to that transition, what went well and what did not do well. So we tried to utilize those best practices to minimize the impact to members and provider disruption as much as possible. I want to thank members of IME staff as well as the MCOs and the efforts in that transition. It was a tremendous effort and partnership on both sides. I think the transition went well. There are several issues with very specific provider types with respect to claims payment, but overall, I do not see any systemic widespread issues with provider payment or member services. We continue to monitor very closely the transition, both with Iowa Total Care coming on board, as well as Amerigroup accepting additional members as well. We meet twice a week with each of those MCOs for an hour and a half each week, and we go through very specific documentation relative to claims payment, claims denial, member services calls, provider services calls. We look at all those top reasons for denials, and we target specific providers if there are issues, and we work through those and identify system changes that need to occur or provider education that may occur as well. When we did the transition, we distributed the population 50-50 through that initial distribution. The intent was we do not want one MCO to have a high percentage of members, specifically certain populations. We don't want that to occur. We did do that 50-50, although we gave the members choice, so they still have choice actually through this month. So July, August, September. We monitored that choice, we monitored the percentages. So you'll see after members' choice is done at the end of this month, I don't anticipate a significant change in these percentages, but you'll see the number. There are about 355,000 members for Amerigroup, about 263,000 for Iowa Total Care. At that point in time was about 618,000, so I was about 57.4% to 42.6%. We will continue to monitor that as we move forward. I monitor that not just by overall population, but I monitor it by rate cell and specific population. So I don't want, for example, the ID population to be 75-25. So we'll monitor each of those rate cells as we move forward. We gain about anywhere from 8,000 to 9,000 new members a month. So our lever is that we can alter that algorithm if we need to ensure that we have distribution as equal as possible. Both MCOs, Amerigroup and Iowa Total Care, I believe went above and beyond to ensure continuity of care for members and payments to Iowa Medicaid providers. Iowa Total Care, Amerigroup, United, IME, we had frequent conversations, frequent meetings during this transition, and it didn't start just July 1st. We started this process back in March and April when we were notified that AmeriHealth or United Healthcare was leaving the marketplace. One of the things I want to call out with respect to Iowa Total Care, when they began coverage July 1st, one of our biggest concerns was the LTSS population, that vulnerable population. So I want to commend them. They had reached out to 97% of their 15,000 members within the first 5 weeks of that transition. Through early September, they've completed nearly 2,300 assessments for those individuals. There were several hundred assessments that came from United that were past due. They've completed the majority of those. Through early September, there were more than 84,000 NEMT trips that have been scheduled and or taken. Iowa Total Care is contracted with more than 37,000 providers across the state of Iowa. Their network adequacy is approximately 98%. There is one area where they continue to focus. It's not where it needs to be, and that's the elderly waiver level 4. But they continue to work with those providers. As of early this month, there were only 64 practitioners and 6 providers that still were in the credentialing process. Everyone else has been credentialed, meaning they're also contracted. Iowa Total Care has paid more than 500,000 total medical claims for about $128 million. They've also paid more than 680,000 pharmacy claims for about $52 million. So they paid out claims in excess of $1.18 million. As Iowa Total Care started paying claims, as I mentioned earlier, there was opportunities to improve their system setup and processing, but as I said, it's not system-wide. It was very specific to certain provider types. Those opportunities have all been identified. There are projects in place. There are timelines that have been developed to correct those system issues. Also, most important is those providers have been outreached to, and they will continue to be outreached so that they understand what that timeline is. Also, Iowa Total Care has been willing and has done manual checks for those providers who have experienced significant cash flow issues. If there were issues with not meeting payroll or they had some concerns with respect to their cash flow, Iowa Total Care has either written them a manual check or in some cases transferred money to their accounts. During the first week of the transition, one of the things that Iowa Total Care did went above and beyond. There was a provider of home meals that at that point decided they weren't going to deliver meals anymore, which affected several, I believe about 100 members were affected by that. Iowa Total Care sent their case managers out into the community, contacted all those members, brought meals to those members, gave them an extra day of meals so they could ensure that they would have food. They also ensured that they contracted with another provider to deliver those meals. One of the things they also did was, as credentialing MCOs, before payment can be made, they must be credentialed with those MCOs. However, there were several providers who had not been credentialed by July 1st, but they had a process in place to make sure those payments were made to those non-credentialed providers. They were contracted, but just had not completed that credentialing process. Again, with the Amerigroup, we continue to meet with them twice a week as well in the transition. They were involved in those frequent meetings and conversations with United Healthcare, Iowa Total Care, and IME as we went through this transition to ensure as smooth as possible as the transition. An example above and beyond for Amerigroup, one member needed assistance with their insulin refill. They had just transitioned from United Healthcare, had not yet received a new ID card, but they were able to get the insulin. Amerigroup went and ensured that that member was able to pick up that insulin so they could continue with that medication. One of the things that I would like to share with you, and you have one of these as a handout, there is a reference guide for you. What that is there are phone numbers on there that if you are hearing of issues, I want to hear about them. So you can call member services, provider services, you can reach directly out to me, you can reach out to Carrie, but we want to make sure we are aware of all the issues either with providers or members, and we are tracking each and every one of those as those emails come to me personally, and we will continue to do that as we move on with this transition. There are two handouts that I'm going to start discussing. So one of them you'll see is an executive summary, legislative requirements. You'll see that document as I start giving you updates on the managed care contracts as well as the requirements from legislation last year. The other one is a pie chart that you'll see which kind of breaks down the state fiscal year 20 rates. If anyone does not have those handouts, please let us know. So, as you know, Amerigroup and Iowa Total Care signed contracts for state fiscal year 2020. Those rates are actually sound and certified by our actuary. They are based on actual experience of our members for fiscal year 18 as that period of time, largely driven by legislative and policy changes, which I'll walk you through in a moment. It's actually important to note that more than half of that rate increase was due to legislative, program, and policy changes. So as you look at this document, it shows the healthcare costs on the very bottom, legislation, the various legislation that we implemented, program and policy changes. So it breaks it down 50.9% or $196 million was due to legislative program or policy changes. And you can see on the left-hand side, $189 million, about 3.95% if you want to look at an MCO rate increase. Lower right-hand corner, it's always important to determine and share with you what we call the medical loss ratio. So if you take a look at this, the non-medical load is 7.8%. That non-medical load consists of the 2.35% care coordination, case management, and medical management activities. 3.7% is traditional admin, so lease, pens, paper, pencils, salaries, those things. 1.75% profit risk contingency, which is a component of capitated rates that are required as actuaries determine those actuarially sound rates. Specifically in the legislative requirements, increased reimbursement for nursing facilities was about $59.8 million. Now I'm speaking in total dollars, not state dollars. It's about $23 million state. There was an additional $12.8 million for mental health funding, $3.8 million reimbursement increase for critical access hospitals. That's being done through a critical access factor. An additional $1 million in state funds, $2.6 million total to the tiered rates for ID waiver providers. That was distributed equally across all 6 tiers. Program or policy changes, LTSS assessments. Members are now able to have others of their choice present during their assessment. MCOs are now required to provide more timely notice to the member for their assessment, so a minimum of 14 days, can be less if the member chooses, but they have to at least give 14 days. Members shall receive a copy of their assessment within 3 days from the MCOs completing that. A policy change relative to hepatitis C funds greater access to hepatitis C treatment for our members. So what we did was, from a policy perspective, we moved from an F4 fibrosis score to an F2, so giving access to more of our members. Provider rebasing, rates were rebased for federally qualified health clinics, FQHCs, rural health clinics, ICFIDs. Additional MCO oversight, the new contracts require the MCOs to load new provider rates within 30 days. It was previously 60. MCOs must complete provider credentialing and accurately load those provider rosters. That's okay. Thank you for joining. Liquidated damages have been increased as it relates to timely and accurate submission of encounter data. Encounter data is extremely important, as that's what we utilize to determine our capitated rates. And penalties have been put in place for reoccurrence of prior authorization and claims payment system issues. So if there was a system issue, they fix it and it reoccurs, and there's penalties for that reoccurrence. Same with prior authorizations, not just claims payment. An update on some of the legislative requirements. Again, it's listed at the bottom, I guess the second page of this handout. Should be going through the same order that I'm going through. Starting on page 2. House File 518, Hospice, Room and Board. We continue to work with CMS on how to make this policy request and how to implement this. We've been told by CMS that this change cannot occur through an 1115, cannot occur through state plan amendment, can't occur through 1915. So we are not certain how we can move this forward, but we will continue to move forward with conversations with CMS. As you recall, this policy would waive the prohibition on Medicaid payment directly for room and board. There were some comments made that Ohio and New York may have already done this. CMS can't confirm that. They know of no authority in which we can do this. Actually, Ohio reached out to us and asked how we were going to do it. So that indicated to me they had not implemented that. But we will continue, as I said. We spoke with them several weeks ago. We're waiting for them to give us a feedback. It may very well come back that they say, you can't do this. But we will continue to work with them and we will update as necessary. House File 570, Brain Injury Waiver Budget Maximum. We eliminated the monthly budget maximum for individuals eligible for the brain waiver, so we removed the cap. It was $3,018 and a few cents. That cap is now removed. That was effective July 1st of 2019. So they no longer need an exception to policy for that. They may access the medically necessary services and supports identified in their comprehensive person-centered plan. However, we must still maintain budget neutrality, so we monitor that through our submission of our 372 to CMS. So we have to maintain that budget neutrality for all of our waivers, not just the brain injury. Children's mental health, HCBS waiver, wait list, 1.2 million state, a little over 3 million in total funds were appropriated to reduce that waiting list. That really equated to about 112 permanent slots. We began releasing those slots July 1st of 2019. We actually released about 500, and we will release another 150 by the end of this month. And I know I'm getting stares at me as far as we only have a 29% uptake, so we have to release enough slots to consume those 112, plus there's some that have opened up over those few months. So it's about 180 is what we're projecting. So that's why we release more than the permanent 112. ACT team funding, so effective for dates of service July 1st, 2019 and after. The ACT per diem rates will be adjusted to reflect actual average per diem with the additional $540,000 of funds that were appropriated. Updates to the fee schedule and the 3 CPT codes and modifiers have been completed. State plan amendment has been submitted. We're still awaiting CMS approval for the ACT team funding. As I said, though, the new fee schedule will be effective for dates of service July 1st, 2019, pending that CMS approval. Tiered rate increase, added $1 million, about 2.9 total in state funds to SCL provider daily rates. As I said earlier, they were divided equally between tiers 1 through 6. It was implemented July 1st of 2019, and there was an informational letter that went out to providers to inform them of that increase. Uniform prior authorization process requirement. We are to adopt rules to require MCOs and fee-for-service to utilize a uniform prior authorization process. A work group convened in August, meeting every 2 weeks. It will be part of our provider training next spring when we move into that time. The tentative implementation is July of 2020. Rules will be noticed, and we'll have those in October as we required by that date. That process is extremely complicated and comprehensive, so that's why it's July of 2020. Other Medicaid updates. As you know, we went to passive assignment effective July 1st. New members are automatically assigned or immediately assigned to a managed care organization. This means that 10 to 45 day period no longer exists. And really what that benefit is is for our long-term support service members, because now they can receive those services much earlier than they did, as opposed to being assigned to fee-for-service for that 10 to 45 days and then being assigned to an MCO and then having to go through the process of getting a service plan and assessment completed. So it's an immediate assignment, so it really reduces that timeline in which they can get those services. Mandatory electronic claims. On August 1st, we implemented a mandatory electronic billing requirement for providers. This applies both to fee-for-service and managed care organizations. We did exempt CDAC providers, so they're not required to file electronically. Dental providers will be February of 2020, in which it will be mandatory for them to submit claims electronically. By going to electronic requirement for submitting claims, we believe that that would be much faster payment for providers, et cetera. It just makes sense to be electronic. The last handout I think that you have that I'm going to walk through briefly, this is something new that we've been working on for several months. I call it an infograph. What I want to do is walk you through the content, kind of the purpose of us doing this, and then as you have more time to digest this, and I'd be happy to take questions at a later time and then provide answers for you to explain the document to you. So what this purpose is on an annual basis, we want to give an overall view of Medicaid. Now, we can do that in a lot of different ways, but what we chose to do is kind of take a look at, okay, here's our population. So as of January, we had almost 700,000 members, or almost 22% of Iowans. And we broke it down by adult and child, wellness plan, the disabled, dual, PACE, and you can see our Hawkeye or CHIP kids. Always been some confusion between what the difference is between Medicare and Medicaid. You know, it's confusing. So we want to make sure that we can delineate that here, so it shows you the difference basically between Medicare and Medicaid. Who administers it, who funds it, whose benefit. One of the things I'll call your attention to are the dual eligibles. So we have about 96,000 Iowans who are dual eligible. So in other words, Medicaid will pay for those expenses for services that Medicare does not. Example would be nursing facility stays over 100 days. On the second page, it's important to know, so who's covered? Not just from, 228,000 kids, but let's put it in a little different context. So you can see Medicaid coverage is in place for about 45% of births, 48% of kids, and almost 48% of nursing home residents are paid for by Medicaid. So you can see the graph below too, almost 1 in 2 births, as I said, 1 in 2 kids, 1 in 5 adults, and you can see, it kind of gives you context about exactly who is covered and why do we do what we do. Also thought it was important to share information by county so legislators can see exactly how Medicaid impacts their particular area and their counties. So you can see the number of Medicaid recipients or members by county, and that's as of January of 2019. Looking at the uninsured rate, obviously Iowa is a Medicaid expansion state. You can see the reduction in uninsurance for our members that was implemented. Next page really goes into cost of care. So kind of taking a look at, how many members, distinct members, what do we pay on the annual basis as of that particular time? Breaks it down by those populations. Also thought we should share services. So kind of taking a look at how many inpatient days we pay for, behavioral health visits, physician and outpatient, nursing facility days. So it breaks it down by those services as well. And then you have almost 30,000 distinct members receiving expanded services or those LTSS services from Medicaid. So it breaks it down by those 7 waivers. And you can see the members and the expense, kind of get a relationship between the number of members, and if it's a small number but it's a great expense, you can clearly see that with these bar graphs. The last page, quality and outcomes. So we take a look at, from a HEDIS perspective, kind of taking a look at how we compare to nation and the median. And I won't go through all these, but you're looking at ED visits, hospitalizations for diabetes, and you kind of take a look from a behavioral health perspective to the preventive services, looking at the trend line for ED use rates, inpatient admissions. One of the things I'll call your attention to is the graph where it says community-based services versus facility-based. So over the period of time, it changed at 3%. So I believe we're about 65% community, 35% institution. So it's like it was 62 and it went to 65, so that's that 3% delta. And that's what we want. We want our members getting their services in the community, not in institutions. So with that, I'd be happy to address any questions you may have.
Thank you, Director. Thank you, Director Claybaugh, as well, for being here with us today. And I know your time in the Department of Human Services is going to come to an end shortly, and so we wish you well back in your other half on the public health side. And thank you for filling in and taking the role that you did. So I'd like to open up the floor to questions. I do have a few committee members. If you have desires to ask questions, please just notify me and I'll get you on the list. What I'd like to do is take it by chunk. Because we talked about a lot of topics here in a very rapid time frame. I'd like to go back up to the first part of the agenda, which was to talk about specifically around the United transition, and if there are any questions from the committee around that. One question I do have, Director, is can you share with us what that final payment to United will look like, when that would be, what we're holding out in that process as they exit the state completely?
Sure. One of the things that I want to make sure that we do is obviously make sure that services will continue for our members. So we had the transition, the file transfers from United Healthcare to the other MCOs. That was first and foremost. But obviously, as important, we want to make sure providers are paid for the claims and services they provided. So what we are doing is we have a claims reserve table and timeline from United Healthcare. So for example, they have provided to me currently what their claim reserve is for all claims for providers in the state of Iowa. I will retain that money, and over a period of time, they will report to me every month as those claims are paid, and I will retain that claim reserve until the claims have been paid. We're also looking at going beyond the end of this year, so it's just depending on how quickly they pay those claims and what those claims reserves are. I'm not going to release all the funds until I'm sure that all those providers have been paid for services and claims that they have been submitted. So it may very well go into next year.
Do you have a dollar amount to that at this moment?
Currently, I believe that the approximate amount that will be withheld will be about $55 million in claims reserve.
Thank you. Seth?
Thank you, Director, for being here today, and I appreciate all this information. It's really nice to have some of this data. It's really good. I have one question about the final payment. We talked about United Healthcare. What about Amerigroup? Are we addressing that today? I still have people that are talking about some of the payments that have not been fulfilled.
What we've done with AmeriHealth, the providers, I believe in early, maybe it's end of May, I think we met with LSA and shared with them that they should communicate to you and other legislators that AmeriHealth will be exiting the market at the end of August. If you still have providers who believe they are owed, then provide that information to me directly. There were a few providers who sent some claims in. There were providers who sent claims in again, but had been resolved with AmeriHealth, or AmeriHealth had said, you know, we believe those were denied appropriately. We right now have a small amount of funding retained from AmeriHealth. I am not aware of any other additional providers who have sent me any email. If you are aware, if they've sent previously, we have reviewed and all of those. If this is a new provider, I'd be more than happy to work with that provider in AmeriHealth.
Outstanding claims that have been through your office have been paid or resolved.
Or resolved.
Resolved, not necessarily paid, but resolved.
Correct.
So that also brings up the question, with AmeriHealth leaving and United Healthcare leaving, are we working on a third company to come in? And where is that process at?
As I've stated publicly before, I think that Iowa Medicaid has been through, unfortunately, 2 transitions. So when I first started, maybe the second day, AmeriHealth Caritas exited that market and disrupted the population. And what that does as well is it makes it very difficult to coordinate the care of our members, as we should be doing in managed care. With United Healthcare exiting the market, again, 425,000 members were disrupted, and that disrupts that coordination of care. I want to bring stability to this Medicaid program. So I don't see any additional managed care organization. I do believe there should be a third.
Well, that's what I'm saying.
I do believe there should be a third. Eventually, there will be a third, but not anytime soon. We need to stabilize this program, ensure our members have that continuity of care, we can coordinate that care, and then we will determine what that timeline is for bringing in a third MCO.
Right, it's certainly seeing how unstable it can be, so, thank you.
You're welcome.
Representative Forbes?
Thank you, Director Randol, for being here today. In your opening statement, you talked about, I'm just kind of curious, the cash flow issues that were being experienced by some of the providers, and you said Iowa Total Healthcare, it fronted them money. Is that, explain that a little bit more.
When we identify those opportunities in system configuration change or whatever the issue might have been for that particular provider type, there was communication out to the provider associations, to those providers that were impacted, and identified and let them know what the timeline was for correction. At that same time, they were asked, do you have, issues with cash flow? Do you have concerns with payroll? Sometimes they have already addressed that or sent me an email or Iowa Total Care an email and say, listen, I can't make payroll. I understand you've got those claims and they're going to be reprocessed when the system configuration occurs, but I need funding now. So Iowa Total Care has advanced them with manual checks and provided funding based on what claims they had submitted, and even wire transferred several transactions for members.
Is the other MCO doing the same thing?
I'm not aware of the other MCO doing that.
Because I know we've had some issues about cash flow with providers here in our state, and it's good to hear that they are willing to help out in situations where they're trying to make payroll and pay their ongoing monthly expenses.
And that's why I brought it up. I think it was, again, above and beyond, because many of the times, the majority of those providers, representative or CDAC, so very sensitive, so we understand that. And so that's why they, even though they were within contractual terms, they went ahead and made those payments because they knew that it was critical for that provider.
And this statement here, when you're talking about your administration fees,
Yes.
Is that averaging both MCOs together, or how'd you calculate that? Because right now we have two. Are they comparable in admin fees, or is one a little more, one a little less?
How we do that with the acts?
Efficiencies, I guess, what I'm trying to find out. Who's run the more efficient program here?
Well, I don't know if I can answer that at this point. We're only 3 months into Iowa Total Care being in the market.
That's not fair.
So I don't know if I want to say one way or the other, whether they are or not. Again, efficiency is kind of measured too, not just from an admin perspective, but the coordination of care, which I talked earlier about the disruption. So how we set the admin rate is we look at part of the process in setting cap rates is obviously we're using counter data, but we also have the MCOs submit to us a very detailed Medicaid reporting template. It's basically a spreadsheet with about 10 different tabs, and it's very detailed by rate cell, by individual, by category of service. And they also submit their admin broken out. So we'll take a look at both MCOs admin. It could be a average of the two. It could be, depending on what the actuary determines, it could be weighted more toward one than the other. They also do a scan around other MCOs and other Medicaid programs relative to what those are. I can tell you that our non-medical load is one of the lowest. I just got a presentation from the Medicaid director in another state and who had presented to his legislature all the medical loss ratios for the surrounding states, and Iowa's very low. Some states are 10, 11%.
It was brought up too, I talked a little bit about this, but when we get into contract negotiations, when you only have two MCOs, managed care organizations, they have a little more control over how they're going to get their funding, and so I would highly recommend that we look at trying to add a third MCO. I know you said you want to get these up and running well, but it gives us more negotiation power when we get into contract negotiations. With two in the game, it makes it, they have a little more leverage on the state of Iowa. So I'm hopeful we can get at least a third one in place here in the next 12 months, would be my hope, I guess.
I couldn't agree with you more. That's why I've stated that publicly. I think that what I want to make sure we do as we bring in a third, and I'm not sure how we do this at this point, but we have to minimize that disruption. So is there a method, is there a model, is there a process we can go through to bring an MCO in and then over a certain period of time, have those assignments as opposed to, all at once? And I don't know what the answer is. We want to minimize that disruption, but I agree, we need a third MCO in here for that very point.
And then when the rollout came July 1, Iowa Total Care, being in the pharmacy business, we have people coming in on a daily basis. The majority of the people that I saw weren't even aware there was a change going forward. And fortunately for us, we had all the information to be able to switch them from the other MCO to the new one. But I just was a little surprised on the number of people that were clueless that they had been switched to Iowa Total Care. So I don't know. I know it's difficult for people to open up their mail and things like that, but if there's a better way we can keep those people updated on, what bit by. You guys use phone calls to people and let them know, or is it just all by mail?
It's mail, it's notifications that go out. We send out hundreds of thousands of notifications for those members as far as their new assignment. We also have, obviously, undeliverable mail that we work through. That particular piece, there could be a phone call. But unfortunately, a lot of times those members, the number that's in the system is not correct.
Yeah. Well, I just made a comment. I mean, it all went well from the pharmacy side, but I would think some other providers that may not have access to the data as fast as we do would have a difficult time determining what MCO they were currently on. So that's all I have.
Senator Blanks.
Thank you, Chair. Thank you, Director Randol, for giving us this information today. There's a reoccurring theme since April of 2016, and that is denial of payment or late payment. And so I think many of us have gotten emails on quality of service, case management, etc. But it seems that the one thing that is still lingering and still strangling some of our providers is this late payment or denial of payment, and going through this, again, I used this the last oversight meeting, this cycle. It's a washing cycle. Are you specifically looking at why there are repeated occurrences of late payment? And if you have, I'm making an assumption here, is it on the side of the provider or is it on the side of the MCO? And what can we do about this?
Senator, it's on both sides, candidly. When we get information on claims denials or an email from one of you or from the governor's office, we immediately send that to the MCO. My account manager for that MCO monitors that. We get resolution. If it is an MCO issue, they have a timeline which they have to develop to correct that. As I said earlier, I've not seen widespread systemic with this transition. It's very specific to provider types. So we have a project plan and a listing of those projects. We go over that project plan twice a week. After each of the check runs, we look at the number of claims that were submitted, the number of claims that were rejected, the rejected reasons. If we see the same reasons occurring over and over, then I'm looking at Iowa Total Care. I'm saying, why am I seeing that reason? We should not be seeing that. Or you have a project in place to correct that. Why is that not corrected? We look at the denial reasons. We look at the top 10 providers who are denied. And if it continues for example, we had one provider, it was 3 straight, I think, check runs, which were they were the number 1 provider and the number. So we said, reach out to that provider and help either educate them, or we need to understand why those are being denied. We will continue to do that. If it's a provider-specific issue, I have told both those MCOs that there's a provider training opportunity for you, because they're providers. They're focused on providing services to our members. For example, they may have not put X80 in box 24J on the, that's something you reach out to that individual provider and say, here's why these claims are denied. And we will continue to do that, Senator. We will never have all claims paid all the time. It's just not going to happen. But we need to get to what I would determine to be a normal denial rate. We have one for pharmacy. It's higher because it's point of sale. But we also have statistics where we have denial rates by provider type. So I can see physicians, hospitals, what are those denial rates? We're not quite where we need to be when what I would say surrounding denial rates in other states, but we're not that far off. And we will continue to monitor, and we will continue to work with those MCOs and providers to ensure those payments are made.
So, thank you for that answer. So, we're hearing still from providers who have been in this since 2016 and have filed claims and corrected claims, and it just keeps going around. They will file a claim with, presumably everything that's correct on it. It's rejected, they fix it, it goes back to someone else who finds something else, it goes back. And they've been doing this now for 3 years. And I think if you ask any of the providers who are here in this room, it's been rather frustrating for them and rather expensive for them. So if you could dig a little bit deeper, I'm asking you to do that as the director of IME, to find out just really what the root cause is. And if it's a software issue, if it is a training issue, then maybe we need to do something differently, because the people who are contacting me are reputable businesses, providers. They have big populations, and it's increasingly frustrating. The other part of this, if I may, Chair, the denial of claims or the late payment has caused some of the providers in my district to just throw up their hands and say that's it, along with low reimbursement rate. But it's the combination of the two that has kind of, they've met a tipping point. And so right now, I have no dentists who are, taking Medicaid patients in Marion. There used to be 2, one retired and the other one just decided not to take any Medicaid. That's concerning to me because we want to have access. That was the reason why I think the governor was attracted to this, was quality of service, reduced cost and access to service. So if we can also take a look at that, maybe for the next meeting, is finding out how many providers signed up at the beginning, and then how many providers of the same providers we still have now. And just, I don't know how you do a maintenance report or how you do an exit interview or something, and find out why did they leave the system? What was the reason? And zero in on that, because without providers, we don't have health care.
Totally agree. So make sure I understand your request. So you want to, for example, point in time, April 2016.
Yes.
This many providers by provider type. As of July 1st, 2019, same thing.
Perfect.
Okay. Be happy to do that. I'm sure someone's actually sent an email already with an RFI.
Are there any further questions about the roughly first part of the agenda here that you addressed? We did go outside that, that's fine. Yes, Senator Dominguez.
I'll be quick, and then I'll delay my other questions later. So just because of the disruptions you mentioned and the changing of providers, each time the providers have to go through this cumbersome pre-authorization process. So is it correct if I would assume that, and I know that's difficult, if I would assume that as the new MCO, Iowa Total Care, gets more experience in our marketplace, that the process of the pre-authorization will get less?
A couple of things. I'll answer that a couple different, with 2 different things, a couple of different things. First and foremost, there was that 90-day continuity of care for PAs, so there were no PAs that were really required. There were some instances where the system didn't really identify that. There was another edit that took place that overrode that, but that was corrected. So we would have that continuity of care for that 90-day period. And the answer is yes. I think when an MCO comes into a marketplace, obviously from a benefit plan perspective, as long as they don't reduce that benefit, they can prior auth if they choose to do that. You don't have to match each MCO and fee for service, obviously. But what we continue to do as a result of the process improvement working group from last year is that we meet, I believe, on a quarterly basis with the MCOs, and we've asked them to, let's identify prior auths that you don't believe are necessary anymore. And if, for example, you're approving 95, 96% of those prior auths, then why are we having that? So we will continue to do that. But I also believe as an MCO enters the market, they may prior auth one particular service because they've had some particular maybe issues in other states relative to that. But once they gain experience here in this state, they may not see that particular issue. They may eliminate prior auth on that service as well. So I would expect it to be reduced.
And then comment, so the past month I queried my patients who are on Iowa Total Care to just my own little survey of their experience. I know it's not as professional as what you all do, but my patients have been pleased with the transition and the services and the lack of disruption to them. That's not necessary long-term care supports and services, that's the other population of Medicaid. So I just wanted to relay that to you.
Thank you.
Thank you, Senator. Questions on the second piece of the presentation, which was focused on the 2020 managed care contracts. I have a couple, 3 questions, and if the committee has any questions you'd like to ask, feel free to jump in. Director Randol, would you just comment on the mid-year review rates, what that process will look like, the expectation? That's one. I'll just lay all 3 of my questions out if you're okay with that.
Sure.
The second question
I have to
is,
remember all 3 of them, those representatives.
well, we'll start with that. Then
Okay.
Go ahead.
They kid me, but I try to be all electronic, and now I've got all this paper sitting here in front of me, and I never have a pen that works, so, no, that's okay.
Oh, they're all kinds
It's all right, I got all kind of pens over here. So what we will do is, we committed in the contract to have a mid-year review of the rates to determine if trend was accurate or was not accurate. So what we'll start doing, this is basically September, so toward the end of October, November, we will be meeting with our actuary, and they will be doing the analysis on looking at the data and kind of comparing the projected trend that we have in the state fiscal year 20 rates to where we really are. We'll do that specific by MCO and then in the aggregate. And at some point, we will bring in the MCOs and start having those discussions that here's what we're saying, and they'll come and say, no, here's what we're saying, and then we'll reconcile those differences and then determine what we need to do, may or may not. At this point, I just don't know.
And any reasons for the legislature, as we come back in the next session, related to that topic that we may get engaged in on those discussions? Or is that conversation that happens among the department of the MCOs?
It really happens between the department and the MCOs because it's part of the negotiations. I don't have any issues as we go through that process as what I can share where we are within that process. I think from a transparency perspective, I have no issues in doing that.
Thank you. Also in the new contracts, the social determinants section and conversation there, could you talk to us as a committee about those pieces that are in the new contracts?
Absolutely, I'm excited about that, but one of the things I need is my MMIS modernization so I can do that data analytics. One of the things we're doing, and it will take some time probably for the entire population, but we changed the health risk assessment in the sense that I think we added 13 questions, and those questions are all social determinants of health questions. So once those are completed, and then what our plan is to bring that information into a data warehouse and start doing some data analytics relative to what is impacting that member's health more. Is it lack of housing? Is it food insecurity? Is it transportation? What might it be? I'm sure it's going to be different by each region of the state, and so we'll break it down by geography to do that. And we'll do what we can with the tools that we have. But I'm very excited as we move forward with MMIS modernization and, fast forward a couple years and we have that data analytics tool that would give us that information in a matter of seconds.
My final question, and I'll open it back to the committee, is the program integrity piece of the new contracts and the increase in program integrity, the robust components of that. Could you talk to us about that?
It's one of those things where as soon as I got here, I didn't believe that we were having enough as far as program integrity efforts from our managed care organizations. I was very honest with them and candid with them. Should be seeing more from that particular. So we've actually made that requirement more within the contract. Part of what we do also in rate setting is I can assume a certain level of collections basically, and part of what you're allowed to do within those capitated rates is you can reduce those rates by a certain amount, and then they have to really go meet that target as far as program integrity efforts. So that's something we do as well.
Thank you, Director. Any other comments or questions about this section? Yes, Senator.
This may be actually on the 21 budget. There's in the budget that you presented, there's no request for any increase for the MCOs for the next contract period. I'm not saying that there may be a supplemental because of that, I just think it's better to be upfront if you think that's going to be there to put it in the budget. So you're contemplating no increase for the MCOs in the next contract period.
That's something that's not been done in this state over a period of time. I can't, as I said earlier, as far as I don't know what those rates may or may not be, so it's difficult to put any number within there. So that's why there's not an increase with the capitated rate. So I simply do not know what that may be or may not be at this point.
So, and can you give me a kind of an update on the cost per member? Usually that's in there too, and I don't believe there was in the last.
I don't have that in front of me, but we can certainly get that information for you.
You send it to all the members, and
Absolutely.
That's probably something you could send before the next meeting.
That's the second RFI that's going out right now.
So that's the other way. But I think that, I hear from all the providers.
Absolutely.
That their rates have not increased, and when we have looked at increasing rates to the MCOs, the boots on the ground are still hurting. So hopefully we also adjust that in some way.
May I comment on that, Mr. Chairman? So I hear that, but I want to make sure we all understand that more than 92% of that funding is going to be paid out to those providers for the services that they provide our members. That's that medical loss ratio. That's the projected medical loss ratio. So we're not giving a big rate increase for the MCOs. I just want to make sure we all understand that.
So let me question this.
Sure.
So you're saying that there could be an increase in provider rates?
No. What I'm saying is currently
Provide more services.
it's utilization.
Services will be.
Unit costs have not increased except for maybe some prescriptions and certain pharmaceuticals. So unit cost, but utilization, membership growth, that's what's driving predominantly. So 92.2% of the projected the funding of the $386 million is going to be paid out to providers for those services they provide our members. That's why we broke that down between the medical loss ratio.
What example could you give me on that for providers? Do you think there's one particular group of providers that will be seeing more of that, or you don't have a feel for that?
It could be primary. It could be a primary care physician group, for example. As we go out and coordinate care for our members, we encourage them to go get their, preventative type services. So as we do that with more and more members, that utilization is going to increase for that particular provider type, and so then you'll pay more out by member. So that would be an example.
Right, they just might want to be more comfortable on getting paid before they increase their capacity.
Certainly.
Thanks.
My list is Representative Brown Powers, Representative Forbes, and Senator Mathis. Representative Brown Powers, you have the floor.
I think I'm sitting next to you, so you can probably hear me. But
I can hear you.
So just a couple of questions. And I love the program outcome and the integrity issue. So kind of on the back of Senator Mathis, the DMEs, are really, so I get on a regular basis that the delay of payment to them. Is this something that you can add into the contracts when you're working with the MCOs, that they have to, like Amerigroup says they're going to pay within certain period, but yet it happens, 30, 40 days, they still aren't getting their payment. So can that be part of that contract that the MCOs have to, if they're saying they're going to pay within a 15-day period, they have to do that? And there's consequences if you don't do that. Because, so the feedback that I get is DME and long-term care are probably the two that are the most frustrated. They're saying, we're doing everything we're supposed to do, but it's 30, 40, 50 days before we're getting paid. So they're having problems with payroll and those kinds of keeping their doors open. So can we make that part of the contract? You said you're going to pay within the certain days, but you're getting feedback from us that it's 30, 40, 50 days that you're not getting, because they're frustrated out there. So they're just looking to us and you as to way to keep these folks accountable for what they say they're going to do as far as paying them back. So do you see anywhere we can push with that accountability?
We currently have language in the contract relative to clean claims, so there's a certain percentage you have to pay within so many days, so it's
Right.
90% within, I believe, 30 days, 99% within 45. I believe those are the numbers. So those are clean claims. We can certainly take a look at additional language relative to some of the concerns that may be
I
addressed.
just think the DME folks, I think they struggle. So I work with people with complex wheelchairs, oxygen, those kinds of things.
Right.
They are really struggling. I had a gal, I called for a simple thing and she kept me on the phone forever because she was just so frustrated. And then we were at a long-term forum the other day and they really were explaining that, they'll send in their claim and then they'll have to come back and maybe fix it. So they'll do that, and then they wait, and then it's another couple days, and they did an example where it was from September to November before they're getting payment. Well, that hurts at that end, and I think it's going to affect our patient care. And quite frankly, that's my biggest concern is patient care across Iowa. I was down in Fairfield, Iowa, and our public health department down there is not seeing Medicaid patients anymore because they weren't getting their payment. So that's sending a message that I think that we need to really make folks accountable for. I mean, you're giving the money, you're really overseeing it, but they're not following, they're not doing what they're told or been asked to do in the contract. So I don't know how we can kind of strengthen that up a little bit.
We'll sort of take a look at that. One of the other things that we implemented last year is we don't have annual training anymore. We have quarterly, and I think what I've asked as far as the quarterly meeting, it is very specific to what the providers want to be trained on. So we have those surveys. I think it's very important that we have those training sessions by provider type. So you may have a DME, and you might have a long-term care, LTSS. So we will continue to focus on that as well, and specifically around claims payment, what they're seeing as issues and training, because we all know that the turnover in that billing department probably is fairly high.
Representative Forbes.
Thank you, Mr. Chair. Just going off Representative Brown Powers, we used to bill a little DME, and we don't do it anymore because we weren't getting paid. And my wife was in charge of that in our pharmacy, and I just said, we can't do it anymore. We can't, it wasn't a huge amount, but we just got to the point where we just aren't doing it anymore because they weren't paying us. So, but my comment was that going off Representative Fry's question is, we changed policy last year to move up the time that you would do your negotiations with the MCOs. And then this year, we were hopeful to get that capitation rate set before we adjourned here later April, I think. That didn't happen, and I think that number didn't come out until, July sometime, or I don't know, I can't remember, but it was at least a couple months after we got out of here. So it's hard for us to set budgets when we don't know what the capitation rate is, so we have to come back the next year and do a supplemental appropriation, which unfortunately we do most years anyways. But the point was trying to make that we would know that number before we got done adjourned in this year's session. It didn't happen. So is there any way you can give us some assurances that we would have that figure before we adjourn next April, hopefully of next year, so we'd be able to plug that into the budget and know the capitation rates for the two MCOs?
Representative, I can't give an assurance or a guarantee that that's going to occur. I will assure you that we do everything we can to ensure we can meet appropriate deadlines so we can share that information. I think what was part of the challenge last year is the exit of United Healthcare and how that impacted the negotiations with the other two MCOs in determining cap rates, because it changed the entire environment, right? So we will start as far as discussions with the actuaries and the MCOs. We have a timeline, but we also have to ensure that we have a certain period of time that goes by. So because we're on a fiscal year, we have to have that base data year, so we have to make sure that year is complete. So I can't determine rates right now, for example. I can't do it in October. I have to wait until that year is over. And so we have the claims run out, correct? So we will do what we can to ensure we have an appropriate negotiation process, and we go through that process as timely as possible. I will, however, tell you that, obviously you probably know this, sometimes those negotiations might be a little tense. So I would rather have an appropriate negotiation versus trying to meet a deadline.
Okay. Well, like I said, it'd just be nice for us to have that figure to put
I do not disagree with you.
and then we know where we're going to be at. So, thank you.
Senator Mathis.
Yes. Thank you, Chair. I think it was the very first oversight meeting that we had, and the three MCOs that we had at that time, I asked them, okay, we're getting started, when are we going to get to innovation? So it's 3 years later, and I'm glad to hear you talk about the social determinants of health. That term has been around for about 15 years. We've even had study in the state of Iowa through our SIM grants. Very, very good results from our SIM grants. In May, I started reading the North Carolina waiver
Mhm.
and the social determinants of health billing code that they have and the assessments around what could be billed as part of that. I called Director Claybaugh. I told him that I was looking at this and trying to build a coalition of approaching IME, DHS, the MCOs, also the governor's office in making sure that we get to innovation, and perhaps this is an area that we need to look at. So I am very happy that you're looking at this. I think we would all like to hear more about it and the development of it, and if there are particular members, I know that our group is pretty far ahead in trying to show some examples of what is working and how North Carolina wrote in their ICD-10 codes reflect that. So can you tell us a little bit more about how you want that to go? Are you thinking pilots? Are you thinking billing codes? United Healthcare came out with AMA in April about billing codes and really pushing that in other states. So what do you see happening for Iowa and SDOH?
I think and again, I'm just thinking out loud here right now. I'm sure that it might change
Go
at some
ahead.
point, because I think that, we need to engage stakeholders and others as far as what their thoughts are as well in the legislature and how we move this forward. But I would think that as we get this information, get the data, and we are able to bring this into our data warehouse, then we'll start doing that data analytics, and then we will probably target specific areas of the state where we have some significant medical issues or chronic conditions are much higher and I don't know this state, so I'm just going to say rural western Iowa. We may have 30% of the population have 3 or more comorbidities. Why is that? Can we point to a social determinant of health? There's no transportation in that particular area, so we would focus on that and see as we move forward versus, taking this statewide. I'd rather focus on where we can get the most value for our time.
I would urge you, since we've had some dismal numbers with maternal health, if we would take a look at that, and the children's mental health, because as we're creating the system, as the board is taking off, and as we're looking across the state and looking at basic access for kids, it's a lot slimmer than what's available for adults. And if we could look in those 2 areas, I think we could really move the needle in some of that. So those are my suggestions.
Thank you.
All right, seeing no further questions, let's move to the next section of the agenda, which was the legislative changes and updates. Director Randol presented on a handout a number of updates as to legislation. Thank you, by the way, that was really helpful.
You're welcome.
We've not had that in years past about certain pieces of legislation that we've enacted and what the department's doing, so I appreciate it.
I want to give the credit to my team. They did a
Good job, team.
very nice job of prepping the Medicaid director for this meeting.
Yeah, excellent. So I have a couple of questions about 2 pieces in there. The first one is the HCBS waiver. Can you talk to us about how many children we're talking about? And then is there the opportunity to be able to get a regular report about how many kids are on the waiver, what's that look like, and so we can be updated as to that process and who's moving and how many numbers we have to talk about?
You're talking about children's mental health waiver?
Correct.
I don't have the number on top of my head as far as how many are on, but you can go out to our website and it lists all waiting lists, and you can see it's updated, so that will give you the information as far as how many members are on and what the waiting list is.
What might be helpful is if the department, here's another RFI, if you could send us.
We can certainly do another RFI, Representative Fry. We will do that.
Thank you. My second question is, not a surprise to you all, the uniform prior authorization process. I've been harping at this for a long time. My question, though, is I'm not sure. You mentioned a July 2020. I thought the legislation talked about an October 1, 2019.
The legislation, and I was very candid with the legislature that we could not implement a uniform prior authorization process by October 1st. There simply was not enough time to do that. We will promulgate rules by October with respect to that, but we have it's extremely complicated when you get through all of the different procedure codes, all the different prior auth requirements, all the different things that we have to look at with both MCOs and IME. We will get to that, but it's not going to be by October 1st. So we will move toward that July 2020 implementation.
So to the emphasis I can stress, July, between October and July, that's a large distance of time. We will have been here and adjourned. I'm going off of what you're foretelling here, Representative Forbes, that we will have adjourned by sometime in April. I would love to see the department move that up. I understand it's a quick timeline, but waiting until July 2020 is a little concerning to me.
So let me say July 1st or earlier. As much as possible, we will do what we can to ensure.
Okay. Thank you. Are there any other questions about legislative updates that anybody had that you would like to get on? Senator Segar.
Thank you, Mr. Chair. Thank you, Director Randol, this morning for being here. How much of a role does the governor's office play in negotiations? Do they have a presence at the table, or is that strictly part of it?
No, it's myself and one or two other DHS IME employees in that negotiation with the MCOs.
Okay, thank you. I just wanted to figure out who was all on that negotiations team. When we started this 3 years
Let me say our actuaries are also in that room.
Okay, appreciate that.
They're in there.
3 years ago when we started, the providers complained about the rates mostly, and that's what you're negotiating in these discussions. Now it seems like it's changed to timeliness of payment. And I get letters every once in a while that large providers may have a $6 million payroll to meet, and they can't guarantee that the check will come in time to make their payrolls. It puts them in a real sticky situation, and I don't know. I think you need to work on timeliness of payment more than anything, so our providers at least know they'll have something there to help pay that payroll when it comes in. So, just two comments I had. Thank you, Mr. Chair.
May I clarify something, please? The negotiations that I do with the MCOs and the actuaries and myself are not for provider reimbursement. It's the capitated rate and what we pay the MCOs on a monthly basis. So I want to make sure that distinction is made.
Senator Miller Weeks.
Run out of water.
Oh boy, so we'll summarize it. One, I don't expect you to know the answer to this now. So just kind of hearing the conversation, I think it would be beneficial to us if we knew what the reimbursement rates to providers, it doesn't have to be individual, it can be groups or categories of providers, prior to the expansion of Medicaid under the old program, and what's happened to those rates, again, in large groups or categories throughout this process. I think that gives us some information because we hear disparate things, and it's very difficult to know without having that data to reply and respond to people whether rates are up or down or the same. That's number one. Number two, contractually we know that you've arranged with the MCOs that payments to be made within 30 days. The payment may not be received within 30 days, so the claim may have been approved within 30 days and payment ensuing, but not there within 30 days. So I think if I'm kind of hearing what both sides and members have said, if we could get information on, so in timeliness of payment of claims, if it's feasible, to get information on when the claims were approved, how many approved claims were paid within 30 days, or the timeline within which they were paid. Was it within 60 days? So providers know exactly what they're looking at. If they're looking at a payment within 30 days for a clean claim, and that comes 40 days, then to them, there's been a violation of that contractual arrangement. Does that make sense?
Yeah, so let me clarify a couple of things too. We don't set the payment terms between the MCOs and the provider. So it may be less than 30, it may be more. I don't know what those relationships are with the provider. So we don't determine that particular.
That's their individual contract.
Individual contracts. The 30 days you're referencing, I believe, is the legislation from last year where they have 30 days in which to load new rates. We did put that into the contract. Used to be 60 days. So for example, if the nursing facility rates increase, and they do quarterly basis, they have 30 days in which to load those into their system and start paying those claims. But we can certainly get you information on the percentage of clean claims paid by MCO. We can certainly get information on average turnaround times by each of those MCOs, so you can see, by provider type, what those turnaround times are.
Representative Representative Lund.
First of all, I too would like to thank you for your service and for providing the information that you've done for us today. I want to touch on House File 570, which was the brain injury, elimination of brain injury wait list.
Right.
I think that really certainly, I know that the department was spending a lot of time granting exceptions to policy in regards to that issue, and you came to us and talked to us about it. And of course, we've had a lot of conversations about other wait lists, whether it was for children's mental health, elderly, etc. I would just like to encourage the department to look at those wait lists and see what else we can eliminate or change to ensure that we have that continuum of care going forward.
Certainly.
Representative Phillips.
Thank you, Mr. Chairman. Director Rand, we've worked over the past year together on the issue with the pharmacy benefit manager, both of them here in the state of Iowa, MCOs. And as you know, I had some deep concerns about what was going on with reimbursement when compared to what pharmacies were being reimbursed and what the state was reimbursed or was being charged, I guess. And as you know, I had an amendment on the HHS bill this year that would have allocated funding to audit both PBMs here in the state of Iowa that serve as our two MCOs. And unfortunately, went through the House very easily and then got to the Senate and died. Is your department looking into this issue, or can you update me? We haven't talked about it for quite a while, but as you know, I had some very deep concerns. And is the department doing anything not right now to look into this or determine if, the data that you provided me was not, in my mind, correct, and there were some very serious billing issues. Have you guys investigated that more thoroughly, and can you update us on that?
Certainly. What we do, and I'll answer that with two different responses. First and foremost, yes, I have an encounter data officer, and that's all he does is reconcile and manage encounter data. And that is part of that process, is looking at the reimbursement, appropriate reimbursement for all pharmaceuticals by NDC code, and looking at the dispensing fee, et cetera. Is it matching what the encounter data states? If not, send the information back and they reprocess. And so yes, that he manages encounter data. That's one component of that. But more importantly, as I've shared with you previously, is how we set the capitated rates in managed care. What our actuary does to ensure we can't have spread pricing in the cap rates is that our actuary actually reprices every pharmacy claim back to the appropriate reimbursement amount, whether that's ingredient cost or average acquisition cost, whatever that might be. So they have an edit algorithm in place that says, okay, I'm looking at this NDC, it should be reimbursed at $100, I'm seeing $105. I don't care, it says $105, I'm going to reprice it back to that $100. So they do that for every pharmacy claim within the data set that they use to set the cap rates. So we will monitor that continually, and that's how we determine when we do our cap rates. So I'm confident that there's not spread pricing within those cap rates.
So you gave me the data for my pharmacy, and I looked at claims that were 6 months out, and apparently it must take more than 6 months for them to go through and do this rebill and reversal, because in my mind, the PBM, the state or the MCO paid the PBM the price. Now, and I'll give you an example. We talked about this. I had claims in my pharmacy where our pharmacy was reimbursed $93 and some change for a prescription, and the pharmacy was reimbursed properly. But when I took the data that you guys provided to me, the state was billed $247 for that same prescription. And there was about a 6 month, maybe 8 month lag in there, so I know the PBMs don't wait 6 or 8 months to get paid, or they would have gotten reimbursed probably within 30 days of that claim. So that was my concern when I looked at that data. I said, so how do we reconcile that I know that claim was rebilled and reversed, and the state was not billed that $247, which in turn increases the cap rate overall. for the state body.
Well, Representative,
That's my concern.
well, let me kind of follow up on your example, 247 and 93. So if that particular claim is in that data set in which we set the rates, that algorithm, that edit that actuary uses would say 247 not right, 93 is the correct amount, and it would reprice it back to that 93. So that difference is never part of that cap rate.
Well, that claim's already been paid for $247, so.
To the particular PBM,
Yeah.
but it's not part of my data set when I set cap rate, so it's not increasing that cap rate.
I guess I don't quite follow that logic, but that was my concern, is that by inflating drug prices, and that's called spread pricing, and it's happened, I see it happen here in Iowa, the state of Ohio had it happen there. They were overbilled $224 million on their state Medicaid program in 2017. And so when I asked for the data from you, I saw the same problem there. And we had a discussion. Remember, we sat with Ohio, we had a conference call with Ohio Medicaid officials one day. And I explained what I found out, and they said that's exactly what happened in the state of Ohio. And so that's why I became very concerned that, we need to be able to make sure that the state of Iowa, citizens here are not being overcharged for prescription medications, and that's why I put that amendment on that bill, HHS bill, and went through the House fine, but then it got to the Senate, and somehow it died. And so I guess we probably need to sit down. I need to see what's going on. I need to see where those claims were actually reversed and rebuilt, and
Be happy to sit with you at any point.
okay, thank you.
All right, seeing no further discussion, I want to thank both of you for appearing before the committee today. Hopefully the committee found this helpful. We wanted to build in plenty of time for questions and us to be able to have a dialogue on these topics. So we thank you for your preparation, for your work, and for navigating the continued changes and direction of MCOs. Director Claybaugh, we wish you well back to your other half of your job, assuming that is full entirely.
What's that?
Thank you, gentlemen.
Thank you. You're welcome.
So if we could have at the table Jeffrey Jones, President of Amerigroup, if he would come up, as well as Sarah Dixon, Chief Strategy Officer for Iowa Health. Plus, we are going to have a conversation today, or at this point now, around the Quality Incentive Program. Senator Mathis, to both of our points in talking about some of these things we want to get to that we've been waiting for. This is the very topic that we're going to begin discussing now for the next few minutes, so we'll have some, hopefully some good dialogue and conversation. With that, I'll turn the floor over to Jeffrey. You are on first, and then Sarah, we'll turn the floor over to you, and then we'll take questions, comments from the committee. We do have 45 minutes allocated for this, so the floor is yours, sir.
Wonderful. Good morning, Senator Miller Meeks, Representative Fry, fellow committee members. Thank you very much for the opportunity. I will be, to Representative Fry's point, speaking to the handout from today's packet regarding value-based purchasing in Iowa Medicaid, opportunities and results. Let's jump right into the slide deck here and get rolling. So a bit of a high-level background from an organizational standpoint. Amerigroup utilizes programs, value-based purchasing quality programs in 18 of our 22 Medicaid states, serving more than 2.2 million members. Nationally, across all of our Amerigroup markets, we exceed 38% of our Medicaid services being performed by providers who are part of a value-based contract. We're actually beating that here in Iowa. We'll get to that later in the deck briefly. At a high level, so value-based purchasing, why do we do it fundamentally? Outlined here are some of the 4 key goals that we utilize when we look at value and partnering with our providers. Improving clinical quality results, improving medical cost management, improving provider operational efficiency, and promoting quality and safe, effective patient care. I mean, this is the foundation, fundamentally, when we view value and what we're trying to do ultimately from a goal perspective. Turning the slide, value-based partnership is exactly it, that key word, partnership. At the end of the day, it's driven by a model that's predicated on collaboration with providers very, very closely and fundamentally. It's about developing the long-term relationships that are required, pulling together the silos and gaps that are in there, ensuring right care, right time, right place fundamentally. Practicing care management support to deliver more effective healthcare decisions. Proven success across several states and markets has provided expertise on how best serve the unique needs of local markets and each patient population. Very important distinction to make, because when we view value, we do try to look nationally and what has worked effectively in other parts of the country, what is adaptable in Iowa, and what can we bring to our Iowa membership ultimately here as well. And then one of the other key components of that partnership model is integrated data, analytics, and tools, obviously, to drive those relationships. A bit of an update specific to Amerigroup here in Iowa. As you heard at our interim committee meeting earlier this year, 2018 was really the foundational year for us fundamentally. Really using that to strategically focus on expanding our value footprint, transitioning from the sole use of the historical unit cost model and moving into an outcomes-based model in which incentives are paid for value, which is represented by improved outcomes and the quality of the services that we're delivering. Our efforts aligned with the IME's goal, also reflecting our contract to achieve a target of 40%. We did exceed that target last year, and eligible members associated with a provider that participates within one of the value-based purchasing programs. Turning to slide 5, steps of the value-based purchasing continuum. We utilize two primary approaches, if you will, to purchase value. Quality incentive programs, which are based on provider type and can be provider type specific, and negotiated shared savings arrangements ultimately. Both are designed to achieve short-term cost reduction along with better long-term member health outcomes, and each leverages best practices, successes adapted from other states, and innovative pilots. I'm not going to speak through the alternative payment model framework graph that's down here at the bottom, but the point I do want to leave you with here is that value is a journey. It's not a one and done. You start in one place and the drive is along the continuum that's represented in this graph here. Some providers will never be in a position to have the technology necessary to do full risk sharing, upside, downside risk, etc. And so it's critical that we have a continuum of offerings, which we will get to here shortly, that address our smaller provider populations, as well as balancing for our larger provider operations and some of our critical partners, such as Iowa Health Plus, that do have some of the technical capabilities to push into a more advanced type of model there. So again, the key point is it's a journey, and with some providers, you can start in the first box and literally work all the way through over time. It's about that relationship maturation. It's about the state's goals ultimately from a quality perspective, etc. So turning to slide 6, we do have a range of agreements customized by provider type, very specifically, that include measurement tools that are tailored to their specific specialty or service offering, if you will. Optional programs we offered are targeted by provider type. 2 of them, and again, we referenced this in our update earlier this year, very specific to Iowa, are programs around nursing facility and personal attendant care. That was a first for our company as a whole, and we did it here in Iowa first, and that has spread to some other states now as well. So we're very proud of bringing that innovation to the table. Obviously continuing to focus on identifying the ways to expand beyond what we'll call the more traditionally targeted provider types, and I'll talk about that here in just a minute. And then the second, again, with a little more detail, and I won't step all the way through here, but negotiated shared savings arrangements. These are the more complex and sophisticated type partnerships. They're typically size-driven. Obviously, the larger the organization, typically the greater the capability in many ways, although not always the case. And there is opportunities for upside-only risk. There's opportunity for upside-downside risk. There's full shared risk opportunities that could be put in play. And again, obviously, the key critical component there is some of the sophistication from the information system standpoint, data analytics, and their ability to manage outcomes to those degrees, if you will. And so turning to slide 8, to give you the best way to obviously step through, and you're hearing these quality incentive plans and they're unique by provider type. I'm going to briefly step through what some of those look like here fundamentally, and we're going to chunk them up into populations. And so from a pure medical perspective, if you will, PQIP, which is our provider quality incentive program, this is our core base value program, if you will, ultimately. Targets medical providers, primary care specifically, with 1,000 plus members. PQIP if I can get away with using an acronym here, I will apologize, but Provider Quality Incentive Program, so I'm going to go be quick so we can get there quicker. Essentials is for primary care medical providers with 250 to 999 members. So again, scale of operation. We cannot simply focus on the largest of the large here because the capabilities are there. You have to drive it down into smaller practice sizes as well at the same time. And then our OB quality, our obstetrician quality incentive program, which includes high-risk members, et cetera, as well. Flip to the next page is our long-term services and supports, if you will. Spoke already about our nursing facility quality incentive program, which was first here, our nursing facility transitions incentive program, and our personal attendant care quality incentive program as well. Each of these is unique in its own right, targets a very, very specific service for very, very specific population, but it has demonstrated value both in outcomes from a quality standpoint and member safety, and we have seen funds being released paying out on these incentive programs. So proof of concept is there fundamentally. Stretch it out now. Let's get it more broadly, fundamentally. Moving to slide 10, behavioral health specifically. Behavioral health quality incentive programs focusing on our behavioral health practices, provides incentives for post-inpatient follow-up, care management, ER avoidance, etc. Pediatric residential treatment quality incentive program. This is focused on our psychiatric residential treatment facilities for minor children. It includes facility performance measures as well. And then last but certainly not least, the behavioral health facility program, which is really focused on inpatient behavioral health care facilities, which can include hospitals, freestanding mental health, substance abuse, and inpatient facilities. So where are we? Well, how did it go, right? So we laid the foundation, we laid the groundwork in 2018. What did we actually realize? And so some of the very, very specific components here, and many of you may have actually seen the press release that went out. We did highlight 7 Iowa organizations. Health Plus was one of those. Very proud of that. That did receive incentive payouts for 2018 fundamentally, all for providing cost-effective, high-quality health care that resulted in better outcomes ultimately for the members. $1.5 million was paid out. Probably doesn't sound like an astronomical number given the breadth and size of our program, but what I will remind you is that 2018 was the foundational year. And so we started 2018 at near zero, and we ended at 46%, I believe, 48% actually, let me correct myself. And so the measures take time to measure, typically a year fundamentally. So as we come to the table in 2020, I will guarantee that number is going to be larger. Again, it's not about the size of the number, but it is about the fact that these incentives are being realized, they are achieving the goals, and we're able to obviously pay for that quality outcome ultimately. The MLRs, so medical loss ratios for those PQIP providers improved by an average of 8.1%. That is moving the needle. I mean, that's very significant fundamentally. And again, our value-based deals now, over 48% of our membership right now is connected to a provider who does have a value-based deal. Improved quality, as participating groups must perform well, and here's some of the examples, and I think Senator Mathis will tie back a bit to some of the dialogue around innovation, what are the outcomes fundamentally here. Adult access to preventative care, well child visits, diabetic testing, cervical and breast cancer screenings, medication management for asthma, and testing for children with upper respiratory infection. The needle moved on every single one of those categories inside the value programs. And so obviously, absolutely need to continue to stay extremely focused on these measures here. And one of the positives of many of these programs is the measures don't have to be static over time. And so A1C testing nailed it this year. It's performing at a level that the program is satisfactory with the results and outcome. All right, on the next. Where do we want to go next as a program and as a state fundamentally? What are those areas we want to improve? These deals and partnerships, more importantly, we have the ability to pivot around those measures to say, okay, for the next year going forward, this is what we're going to be focusing on fundamentally. That's really where the collaborative piece comes into play overall. Turning to page 12, continuing from the former slide, again, the groups are measured on quality performance based on how they compare to their peers. and how much their quality scores have improved year over year. So it's not in isolation, it is quite frankly how they are doing compared to those that perform the same services within the marketplace. In the PQUIP program for 18, again, providers met key goals for areas including children and teens visiting doctors, receiving their WellCare appointments, improved access to preventative care, and higher rates of cervical cancer screenings. The emphasis on high-quality primary care leads to individuals staying healthy out of the hospital, resulting in long-term cost savings, ultimately to the Medicaid program. So turning to future goals, and for 13, slide 13 here, if you will. First and foremost, continue to increase program participation in statewide footprint. We're not afraid to break down the boundaries of what's a traditional quality incentive program, if you will. And what I mean by that is we want to target those providers that historically may not have had access to something like this, but could value from it. Because quite frankly, those incentive payouts drive infrastructure, drives their ability to improve their technical capabilities as well as their care providing platforms as well. So truly believe very strongly in increasing that footprint as we move forward. Provider engagement leads program, improving that. It's inherent, it is a collaboration, it is a partnership. To do it successfully, it has to be very, very high engagement with the providers. Improving care coordination overall. Physical and behavioral health integration. As you can see, a lot of these components here should be connecting for everybody with some of our broader initiatives across the state to deal with our mental health system, et cetera. All these are levers that can be utilized to some extent. And Senator Mathis, again, I hate to keep referring to you, but in the previous discussion, as we were talking about, how do we pilot, how do we come together, how do we identify new opportunities? I think the first answer is we have to have the conversation. And we have to be willing to explore it differently than we had in the past. And there's probably going to be 10 ideas, and 8 of them may be a little out there, but it's those 2 that are really going to move the needle that we got to nail here ultimately and fundamentally. So very excited about that component. I think it's a great opportunity. Continue to drive down lower medical loss ratio, addressing the total cost of care for the state, if you will. And then continue down the continuum towards risk with providers that are ready for risk, that are prepared to move in that direction ultimately. So that concludes my portion of the presentation this morning. Very happy to take questions now. After.
Why don't we go ahead and move to the second half of the presentation so we make sure we give you plenty of time, and then we have to take questions short, to be honest.
Thank you.
Well, good morning to all of the committee members, and thanks for your public service. Our CEO, Aaron Todd, sends his regards, and I'll do my best to fill in for him today, and really appreciate the opportunity to speak with all of you. I think you'll find that the presentation we prepared, I think, really nicely aligns with what Jeff shared, and I appreciate being at the table with him today as well. So just to give you guys a sense of who Iowa Health Plus is, it's actually a network of federally qualified health centers that have agreed to come together to work within the world of value, and really think about what we can do to impact costs and quality. There's some history about how many patients we serve across our network in all payer types, as well as just our involvement with different ACO opportunities or accountable care organization opportunities that we've been involved with going back to 2011. And you can also see where the health centers are located in the state that are involved with Iowa Health Plus. The slide that talks about organizational alignment, really what I wanted to the main point of sharing this information with you is just to demonstrate that we're really trying to leverage resources across 3 companies that we work on behalf of the health centers. And you need all 3 of those components, I think, to really come together to be effective in transformation and preparing for and succeeding in a value-based world. And so we have a health information technology company in yellow. The PCA, the traditional organization you guys probably are most familiar with, is in blue. And then Iowa Health Plus is in red. So just wanted to share what our infrastructure looks like across those 3 companies. I also included the APM framework model in the presentation, and Jeff did a really nice job of explaining, why point to that, why is that important to focus in on. And just to give you some context of the Provider Quality Incentive Program, the PQUIP program, that would really fall into category 2 in that scale or that spectrum. And as Jeff said, there are providers in the state and elsewhere that are moving and progressing along that scale as they build the infrastructure to be successful. And we think primary care is the backbone of doing that well, and are really excited to be have opportunities and partnerships with payers to move along that spectrum as well. Just some, the next slide, history of innovation and partnership, that gives you a sense of the types of organizations that we've been partnering with to do more around total cost of care and quality improvement. And so we did have payer agreements in place with United Healthcare before they exited the market. Obviously, we're here with Amerigroup today. And then we really look at our partnerships more broadly than the payers as well to help us prepare for and deliver on what providers need to do to effectively move the system. So just other examples of what we've been doing. I think what I'll highlight on this slide is just Jeff talked about how it does take time to move the needle, and we did experience that with another payer partnership. It took us, over 2 years, we were able to move the total cost of care measure down by double digits, so 28 percentage points. And we didn't see that, we didn't achieve that in the first year. That was a 2-year initiative to get that type of result. And so when you have continuity with the partnerships, your payer partnerships, you can certainly achieve a lot more when you're building over time. If we go to the PQIP area, focus areas for Iowa Health Plus, this will dive a little bit deeper into the things that Jeff mentioned. So these were specifically the measures that Iowa Health Plus was working on in 2018. Those 4 top measures, they're HEDIS measures, so it's a kind of a way of looking at the quality that healthcare providers are bringing to the table from a payer perspective. You'll see that we were working to get adults in for preventive care. We want to see patients at least annually and more if they have chronic diseases as primary care providers. So that really measured, are we engaging with all of the patients that are attributed to us? Cervical cancer screening gets right at what the measure says. Are we getting people in timely for those preventive screenings? Are we effective in engaging patients and coming in for those visits? Same with adolescent well care and then the well child visits. And these measures were selected by Amerigroup when they looked at the types of patients that are most likely to be in our attributed population. So really trying to run at areas that would bring the most value to the system. And then you can see the little plus sign on that slide with the medical loss ratio improvement. And so the PQIP program brought in not only quality, but then a cost aspect to the work that we were doing to reflect that we need to move on both of those components. And for that, we did focus on a reduction of ER use. So that was something that that was our total cost of care intervention. The next slide is just to give you guys a sense of how we are trying to organize the way in which we provide healthcare services and supports to vulnerable patients in our state. So we do have initiatives that look specifically at integration of care. We're lucky that we are able to provide oral health services and behavioral health services, as well as other social support services as a federally qualified health centers. They've done a lot to invest in looking at the whole person, and so integration is really important to the type of care that we're trying to provide. We want to be able to be accessible to patients when they need us, and so lots of initiatives around making sure that we are available when patients need us. So you've seen health centers across the state really think about what hours do we need to be open, can we be more flexible to accommodate the needs of the people that we're serving. Lots around high-risk care coordination and managing patients' transitions of care. A lot of that is focused on when patients are in the hospital setting, the role of the primary care provider in engaging that patient post-discharge and ensuring that the patient not only understands what they're supposed to do next, but has the supports and access to primary care supports and services when they've had an incident that's led them to be in the hospital. And then on the front end, I talked about our work on reducing ER use. We're trying to get ahead of that issue. So we call everybody that's transitioned out of the hospital, but we also, for those that are using the ER in a way that we would like them to come in and see us first, we do that education alongside, because it's a moment where you can engage with the patient, I think, in a different different way if they've had an incident where they needed the support of the health delivery system more so than they typically would. And then high quality care, that's just all of the work that we do from a population health management perspective. Are we aware, are we following up on the patients that have gaps in care from a primary care perspective to keep the patients healthy over time? We've also placed a large emphasis on social determinants of health and capture standardized social determinant of health data on many of our patients, and are starting to use that to inform not only interventions from a specific patient perspective, but also when Mike and Jeff were talking about, you could start to look at trends geographically and otherwise in different populations once you have that data available. You can do more with your communities as a provider if you can bring that data to the table, and I think we can do more as a state when we have a better look at all of that. So just wanted to give you guys a sense. I thought it'd be helpful to show you the investments that we tried to make to be successful in this partnership with Amerigroup. So we do have an interdisciplinary team within Iowa Health Plus that really supports the health centers in living and breathing and making improvements to their ability to engage patients, to do the population health management activities that we need, to provide critical care coordination services to patients who are frequent and high users of the system for a variety of reasons. And we interact with the care coordinators from the health centers about every other week to talk about models of care. So very hands-on, collaborative. It gives all the health centers a chance to also learn from one another. And so we've developed a lot of models of care that support not only the HEDIS measures that we focus on the PQIP, but also just reductions in the total cost of care as well. And that is, it takes a lot of time, but when you write that down and you start to change your policies, your procedures, your processes, your workflows, that's when you can really start to see change in a system. And each clinic is a complex animal, and I think we can't underestimate how much support is needed to make changes at certain times with what we're working on. And then the last piece I think that's really important is the ability to have data at your fingertips. So we talk a lot about timely and actionable data. Both of those things are really important. If we don't have information about a patient that's come out of the hospital, for example, in a timely manner, it's hard to intervene with them. Those individuals are more likely to potentially end up back there if we aren't providing that support when they come out of the hospital. So we have invested in an analytics system that helps us make decisions about how we invest our resources to close gaps in care, as well as what's driving the costs of the care that we're seeing within our attributed membership. So then the PQIP results, this is a fun part of maybe the most fun part of the presentation, and just sharing what our results were from 2018. And so we were measured, 2017 was our baseline for the medical loss ratio measure, and what you can see in 2018 is that we saved nearly $6 million in medical expenses. And our contract and agreement with Amerigroup allowed us to share in 20% of that total savings. So this is where a series of kind of calculations occur to get us to the amount we ultimately earned, which was just over $650,000. So that earning was a combination of how we performed from a medical loss ratio perspective, as well as how effective we were at closing care gaps on those HEDIS targets that I talked about, cervical cancer screening, adolescent well care, things like that. And so you can see we earned 55% of what was available based on our quality measures, and then because of the reduction in MLR, we were eligible for that initial 20%. I want to be really transparent, and I'll tell you guys we left about $300,000 on the table because of our performance on quality, and so I can tell you that the health centers are feeling very motivated to close additional care gaps and think about the ways that we can engage the patients we weren't able to touch. And so that's a really motivating, I think, force for the health centers, is just to see what we left on the table and what we could have earned if our performance had been even higher. But we were really proud of where we landed on those measures. And then also just on the slide, touching on the fact that the shared savings that we earned as a network, we're we're reinvesting that into network capacity. So what more can we do around data analytics, data sharing and information sharing? What investments can we make to support the care coordination services we're providing? And then we made a distribution to all of the member health centers based on their individual performance as well. So there's accountability built in to the way that we're distributing the funds based on performance to the centers too. And then just to round out my presentation, just what's next. I think for our network, we will continue to optimize our data systems. There's a lot of opportunities now that we have a more robust system stood up. So I think the number of innovations that you can work on based on that data is pretty endless. Social determinants of health will be at the forefront of the way in which we're trying to marry data sets to hopefully support and intervene with patients that don't just have medical complexity as an issue, but also have some very significant social complexity as issues. And then we're always looking for partners, that want to support a payer-agnostic way of providing really good primary care. And so when we're looking to partner with either the Medicaid MCOs or other payers, we're looking to leverage and work on, consistent topics so that our system is responding most effectively. If we have 20 measures, we're not as good as if we have 5 that we get really good at, and then we can move on from there. Continuing our progress on our quality and performance improvement efforts within the health centers, making sure that the changes that we made are sustained and we continue to deliver on those 4 HEDIS measures at the same rates and hopefully improving too. And then we do want to progress against across that value-based pay spectrum over time, and really need the partnerships with payers to determine where do we best fall. Are we well positioned to move on to the next step? So we'll be looking at that. And then lots of support for leadership development and change management at the health centers. All of these initiatives require people to do things differently. And I think what we're finding is that when we solve processes that haven't been as effective or efficient, our people can be best able to perform and support patients in the ways that they need it. And so that's really the end of my presentation. I'm looking forward to the questions and dialogue with all of you, and appreciate the opportunity to present.
Thank you to both of you. This is exciting because this is where we've wanted to get to. This is the conversation we've been waiting for a few years now. So thank you for coming. Thank you for being willing to jump into it and to push forward with the partnership and to engage one another. Jeffrey, a couple of questions that I have for you. First of all, what are the provider types are you now targeting, looking at, and moving towards? Second question is, what are the barriers that have kept you all from getting this going, or that you want to learn from in pursuing other provider types?
Yeah, thank you, Representative Fry. I think from a focal standpoint, certainly want to stretch even deeper into long-term services and supports, LTSS populations and our HCBS waiver providers, finding unique opportunities there. We also want to continue to expand on our obstetrician program as well, our OBGYN program, to make sure we're maximizing that care platform as well. Those are some of the areas where we're really, really focused. I think on the other side of what some of the barriers have been, I think fundamentally at times we didn't move fast enough. We found there were some providers in this state that were out ahead of us, and we had to kind of catch up to that. And I'm comfortable saying that out loud because we are there now. And quite frankly, we were able to learn from them through that situation. And so it was very, very helpful from that standpoint. I think one of the other barriers we run into from time to time is there are those that believe they understand what quality programs and outcomes and shared savings and risk really are, but aren't necessarily really willing to put skin in the game to achieve that. And so it's a difficult conversation to have about how we're going to move the needle, how we're going to move the bar, but yet they don't want to put anything at risk in the relationship. And so pushing to that even playing field at a minimum and then to taking some of that downside risk is the ultimate place to go. And so that's been the bigger stretch, Representative Fry, is getting that next level, if you will. But we're moving in that direction. It is getting there now, but that has been one of the barriers.
Would you add anything, Sarah, to that question about the barriers that you've experienced?
Yeah, I think it's a great question. I think Jeff's response is really good. I think that when you guys were talking earlier about some of the challenges just with payment and things like that, I think once those things get worked out across the state, and we have a good sense. It does allow providers to then enter into negotiations and be thoughtful about the way that they're partnering with our payers. But those basics have to be working in order to do that well. The only, I think the other challenge I would just, for those that are thinking about getting into this type of, these types of value-based arrangements is just, it does take a lot of data analysis and time to negotiate, I think, really thoughtful agreements with the payer partner. So we've really appreciated the dialogue with the payers, but it does take a tremendous amount of time to get to a place where everybody feels good about how to move forward. And I think data sharing is an area of, where we could certainly make improvements. I think attribution of patients is an area where we can certainly make improvements. And we're also supportive of just changes to prior authorization types of things so that our clinicians can focus their energy and resources on delivering the care. So all those things, I think, come together to make value-based arrangements, most effective.
I think the legislature will be interested in how we can help move that along. So if there are ways in which we can be helpful in that conversation or legislation verbiage that needs to be sought after, we'd surely be open to that conversation.
Thank you.
Others? Senator Miller Meeks.
Thank you very much. So I have just a couple of questions and a remark. One is that being a new legislator, one of the things I found out as I came into last session was that our previous Medicaid program, one of the benefits we've had with the MCOs is that we didn't have the data analytics that are available to push us in this direction. So what I'm hearing from you, both of you, on the provider side and on the insurance side, is that the data analytics were critically important and that we need to continue to work in that vein with data sharing and then attribution rates. So I think this is something our state has gained, and we're very appreciative of that. Then the next question I have is actually for Sarah. Did you pick the quality measures that you wanted to focus on? Or did Amerigroup pick the quality measures for you, or was it a collaboration between the provider group and the insurance group for those provider measures? Was it based on data that you already had in your group of patients that you said these are things we're lacking, so we're going to focus on this? Or was it things on the insurance side that it was costly and they wanted the provider group to focus on that? Can you share how you picked those measures?
Sure. So I'll give you the experience we've had both in 2018 and 2019, because we're also in an arrangement with Amerigroup this year. So in 2018, the PQIP program, Amerigroup looked at where the prevalence of our patients were and the largest gaps that we had from those measures. So those were selected by a review of data by Amerigroup, and we were supportive of those things, of course. And this year with our value-based arrangement with Amerigroup, we did negotiate what the HEDIS measures would look like. And I would say that I think when you come to the table, what we've found is that we're all trying to work on the same things. It's just maybe a little bit of a different lens that we bring when we're talking about how best to solve those issues. But we ended up with 4 HEDIS measures in our contract this year, a measure that's looking, of course, at the total cost of care, and then we wanted to do more to formalize the way in which we were doing something to reduce the emergency room use in the population.
And if I could add, Senator Melanie, I apologize, Representative Fry. Just want to say I think the answer should be all the above. Everything you described. And when we talk about that continuum, again, as Sarah pointed out, you may start in one place, but as that journey progresses, the conversation gets much more dynamic and the approach gets much more dynamic as well.
That's where I was hoping we'd go, that, to leverage the information, the data analytics you have, but also tailor it specifically to their group and their patient population.
Correct.
Good. I have on the list Senator Mathis, Representative Forbes, Senator Segevar. Senator Mathis.
Thank you, Chairman. Sarah, the FQHC's very motivated to do this too, so thank you for working with them and getting this done. I think, and correct me if needed, that when we expanded Medicaid, they took on more patients. And I think Director Randol said, monthly there are thousands that are enrolling in Medicaid, and so it seems like our health centers, our federally qualified health centers, are seeing more of the population that really needs the help. And so even though they were, they received a bonus check back to the increased population, that that they're serving. I think now they have some waiting lists where they didn't have waiting lists before, so hopefully that will help them, tackle those waiting lists. So thank you for your work in that. Jeff, thank you for being here. On page 4, you have the ongoing strategic transition, and going from an outcomes-based model in which incentives are paid for value represented by improved outcomes and quality of services delivered. So you also mentioned the LTSS community and that you really want to, in this next year, focus on the LTSS community. And we've, for a number of meetings and years, said it's really hard to show improvement there. So how are you going to start? The parents and the caregivers and the members are waiting to see some, really good results from this population. So where? What are you going to do?
Absolutely, great question. And so what I will say, first and foremost, is that there is work going on organizationally right now to identify some of those opportunities. So I don't want to get too far in front of my skis here fundamentally, but I think that in that circumstance, as you described it, which is very, very accurate, Senator Mathis, it can't be, okay, we're going to move on then because we don't see that there. It has to be, well, what should it be then? And is it based on the core continuum of care in that circumstance, because it's so vital that, quite frankly, the minimum care has to be realized versus the outstretched and the more advanced components. And so I think there's a degree of flexibility that has to be applied fundamentally to that population to come together on what those opportunities are. And I suspect that I have some meetings coming up here very soon where we'll be speaking with some LTSS providers that I believe are going to be showing some of those opportunities for us. But at the same time, working with our national partners to say, do we have anything that has been successful in other states, or anything that got close in other states that we should be exploring right now? I have an outstanding request right now we're working through, and the organization knows I want more ECBS-focused incentive programs in place. So there is active work going on there. So I hope very, very soon we'll have more concrete information to provide.
So last year about this time I asked you, how are we doing with innovation? You said we're getting there, and clearly you've done a lot in a year. So we still have providers who are saying that they're not being paid on time. And you've heard the comments by Director Randol. What are you doing to fix that? And what do you see as the biggest obstacle in all of this? What is it?
So Senator Mathis, if I could, I have a very thorough update for that in my next session here.
Okay.
So if you don't mind, we'll defer that until we get to the MCO update and absolutely have that covered.
Sure, thank you. Thanks.
Representative Forbes?
Share this.
Well, thanks for being here today, for your presentation, and this is really what the future of healthcare is going to be, is quality of care measurements and better outcomes. One of the things that I didn't hear you talk about was being a pharmacist. Prescription drug costs are continually being a cost-driving factor in all healthcare plans today, and I didn't really hear you talk a bunch about medication management for patients in your programs, because many of the patients that are on multiple medications, 6 or more, have a difficult time of being able to manage and keep track, and they get confused. And so what are your groups doing to help patients in that arena be able to make sure they get, can manage their medications more effectively, which in turn will probably lower healthcare costs overall?
I'll take that first and then I'll...
Yeah, I'm happy to take that. Thank you for the question. I'll talk about pharmacy maybe in 2 different ways. So one, from a total cost of care perspective, there's a state formulary that's set. And so, we need to stay within those bounds of using the formulary. So in terms of like driving costs in a different way, we're a little limited in our ability to look at prescribing. I think your point about medication management and making sure that we're supporting patients in not only having access to the medications that have been prescribed to them, but also that they're taking them appropriately and aren't cutting them because of costs or anything like that. We do work on that specifically. So in some of our health centers, we have a clinical pharmacist that is serving as a partner in our care coordination methodology, who can look at med adherence, med management, and really bring the skills of the clinicians and care team members up to make sure that patients are titrating up appropriately and things like that. I think diabetes is a really good example. We've done a lot of work on diabetes prescribing algorithms to ensure that patients are taking medications that help to get their hemoglobin A1C back into control. I think this is another area where I think we have a lot of opportunity for innovation. Our new analytics system is certainly going to help us to look at gaps and see that patients aren't picking up their medications, for example, at the most basic level. So when we can get claims data into our analytics system, we can identify patients that are having those types of issues, and then obviously hope to do more from an innovative clinic support perspective as well.
And Representative Forbes, what I would add is that from a measurement and analytics capability, we do absolutely track prescribing patterns, utilization patterns from a pharmaceutical standpoint by provider, by group, by organization, so we can see the trends amongst peers within the provider community, where their prescribing patterns are. Again, the data is a really critical piece to that, though, fundamentally, and making sure that, okay, well, this provider is prescribing more than this provider is. Well, it doesn't, right, it's table stakes. Then you got to get into, okay, well, why? And what's the proportion of membership that provider cares for? And what is their level of acuity, if you will? And so it's a lot of false indicators sometimes. So, but to bring it back to the core question, absolutely we are focused on prescribing patterns and do utilize that information in our value partnerships. And again, it gets back to that continuum, and that's getting a little bit of the more advanced component of it, but it's absolutely where we are going. Yes.
Good.
Senator Segabar.
Thank you, Mr. Chair. Thanks, guys, for being here this morning. Dentistry seems to be a struggling need out there because dentists are not accepting Medicaid patients. Is there an incentive program for dentists?
Unfortunately, we don't hold the dental contracts, and so I would have to defer that to either Director Randol or one of the dental MCOs.
I figured he was involved in that.
Yeah.
Thank you.
Representative Lundgren.
Thank you, Chairman Frey. So earlier today, we heard Director Randall talk about the social detriments of health. And I'm sure you have done a lot of work surrounding that issue. But my question is, how are you going to build that into your value-based purchasing and the outcomes? And if you're collecting that data, how do we share that with the state, or how does the state get that data to you so that we really see more of a holistic approach, especially when we're talking about the FQHCs? I mean, it's certainly probably one of the demographics that have more surrounding their lives than just the health aspect.
Absolutely. I think, you guys keep pulling me in my next update here, and I love it. I will be talking more about social drivers of health in my next presentation as well. But I do think, plainly stated, you have to start somewhere. And to the point, to gather the information, when we're talking about social drivers of health, you don't know if you don't ask, you don't know if you don't track, you don't know if you don't monitor. And so getting the value programs in place, all of a sudden you hear the data that now starts becoming available and gets to be, quite frankly, part of the conversation. So if I was sitting down and Sarah and I were having a dialogue about a specific member base in a specific clinic, that conversation could turn into, well, what are the other external factors that are impacting those individuals? And where can we intervene? And if we can intervene, what can we do to change that fundamentally? So again, it's part of the continuum. The information gathering piece is a really critical part. But I will be talking about a couple specific social drivers when I do my other case.
All right, thank you both for being here today. And because we are wanting to get to your next presentation, let's just roll right into that next topic, and we'll roll on with that. So Jeffrey, you are up also for an update from your NCO's perspective. Look forward to hearing that.
Wonderful.
Thank you, Sarah.
Absolutely. And if I could, first and foremost for the committee, I apologize, but I'm going to be that guy today and hand out an attachment here at the table, so I do apologize. So let's see if I can do this as efficiently as possible. We'll split them up, and we'll start this way. If you take one and pass it down. And Representative Forbes, I'll start you on this end here, sir. Okay, great. Thank you again to the committee for the opportunity to provide additional information on the value-based purchasing program. Obviously, a lot of energy, a lot of passion there. It's going to change. It's going to evolve. We are absolutely committed to doing that over time. Turning over to our MCO update, what I'd like to do today with our time is to provide some key updates related specifically to our transition efforts over the past several months following the departure of United Healthcare. Hopefully give the committee some more context around some of what we've been experiencing, and also address heads-on what some of those issues have been we've had to work our way through. Overall, we had many accomplishments. We're very proud of what we've gotten done in this short period of time, fundamentally from a membership transition standpoint. We have had a few challenges. I will be using the one-pager throughout the presentation as we step through here. We will start, if you will. There's my version. I handed it to everybody else, so I've got to have mine out here. Up in the top left of the membership piece. So at the end of June, just to give you a bit of perspective, Amerigroup was sitting around 240,000 members. At the end of August, we're just north of 388,000. For those that are tracking Director Randol's math, my number includes Hawkeye membership. So just to make that distinction there. And so from an increase standpoint, we saw a 61% increase in our membership base between June 30th and the end of August, if you will, fundamentally. To get even more narrower there from a long-term service and support standpoint, you can see our June membership just south of 12,000, 103% increase in our LTSS footprint. 12,252 new members. And so to count for that new membership, we had to do a lot of things. But one of the most critical ones, you hear the numbers and it's, that's right. So recruiting, hiring, training, absolutely critical out of the gate, and how can you do it as quickly as possible? And so, not on the page, but some statistics I did want to share with the committee today. We added nearly 400 new positions to support this membership. Out of the 400, 288 of those are home team Iowans, so they're right here locally in my health plan. 120 to support our broader infrastructure, claims, call center, etc. Locally, so very specifically, our local home team, 268 positions we increased, 72%. And so we moved from 372 associates to 640 here in Iowa. In LTSS specifically, this number is going to be a little bit different. We had to add over 174 positions, 96% increase in our staffing there fundamentally. For our community-based case managers, we added 130, which is a 110% increase over the volume of community-based case managers we had prior to the new membership. So wanted to share with the committee just to give a little bit of breadth of the depth of recruitment and hiring and training we had to do within this 90-day window to be ready, if you will. And I think that as it speaks to LTSS specifically, if I could continue on that thread, we knew that one of the keys to success was to find the talent where it existed already within the state of Iowa, which means we had to form a very connected to our partners at United Healthcare, and we were throughout this transition very successfully, specifically from a recruitment standpoint. So we knew that fundamentally how to get out of the gate the quickest would be to take community-based case managers that already exist in the community, are already serving our members, already understand the program rules, and then bring them on board, and we have to teach them our systems and our nuances of our process, but the ramp time is a lot quicker to get that done fundamentally. And so using that tactic, we were able to leverage their program experience to get moving a lot quicker on July 1st. One of the balancing acts we had to do was United had members they had to care for until June 30th. And so we knew we could not go hire that staff earlier, because if we did, who was going to be caring for those members in that circumstance? So there was a delicate balance act that was intentional and planned as we stepped through that piece there. And we're grateful for the opportunities we had there to do that effectively. And so the next component from an LTSS standpoint in hiring is matching case managers or existing members within the communities they already serve. That was a very next critical standpoint. So at all costs and at any point, if we hired a case manager and we had their existing membership move over to us, they were automatically assigned to that member. So they retained their caseload, if you will, or the members they had. Now, sure, they picked up some new ones for sure, given the disbursement of membership across the state. But if you were a case manager we hired and you had an existing member that is now with Amerigroup, they were absolutely assigned to that case manager, again, to preserve not only the continuity of care, but preserve the relationship, which is an intimate one in that circumstance. So really, really emphasize that to the extent we possibly could. A lot of proactive work on reviewing authorization data and making any corrections and any gaps there, if you will. And that type of mass information moving when you think about authorization data, and then you think about long-term service and supports authorization data, exponentially greater. There's a lot more there that has to move, making sure we had the care plans, we had all the right level of details, down to the minutia of do we have the right units for a certain service loaded in the system accurately. All that work was happening during this transition period very, very aggressively. And as an example on the bottom left here, just to put it in context, May to June, our LTSS team did 1,200 assessments. July to August, doubled, overnight. So clearly the numbers, the good news is the numbers are trending consistently with the volume of membership. But again, just to give the committee a feel for the volume of work that had to happen during this 90 days, lights were on July 1, everything had to go. And so very, very proud of the work we did there fundamentally from LTSS, and continue to look forward to a very solid execution. If I could turn to our claim performance in the top here. As you can see, our performance continues to exceed our contractual standards, and so I'm going to add some additional commentary to Director Randol's earlier today. And first, what I want to demonstrate is, if you look at the total volume for Q4, state fiscal year 19, so that was April through June of this year, you can see the claim volume, 965,000.5. 7-day payment, 94%. 30-day payment, 100%. And I want to clarify, that 30-day measure is not time to process a claim. That is to adjudicate and pay. And so the measure is wrapped up together. And so when we move to July and August performance specifically, you can see for 2 months we've already surpassed our claim volume normal for 3 months. That would be anticipated. The 7-day payment is sitting around 90%, and our 30-day payment still well exceeds our contract requirement of 90% within 30 days. However, some of what we have been navigating and feeling is in that 7-day payment bucket, and this is why I wanted to share this with the committee. I normally wouldn't bring a 7-day payment stat here because it's not a contractual responsibility that we have fundamentally, but I do it to demonstrate when a provider says my payment is slowed, and if they were used to getting their payment in 7 days, and because of the 55% increase in claims that happened so quickly, and as we were adjusting in those volumes, if that payment came in 14 days, to some providers, that miss of 7 days was significant, especially some of the smaller providers. And we had to do things specifically to support them in that circumstance. So I know it's not a statistic you would normally see, but I wanted to do it just to articulate. And you can expand from there. If they typically got their payment in 14 days and now it took 25, still within contract standards, but their revenue cycle, if you will, their accounts receivable were thrown off by that to some extent. And it impacted different providers in different ways, but I did want to share that piece. And so to that end, what we've been doing, first and foremost, we fully anticipate that as we move into the beginning of October, that volume stabilizes. Those turnaround times, we fully expect to get back to 94% in 7 days or very, very close to it. However, what we did have to do in many circumstances was get on the phone, and we had to work with some providers that were in a bad spot. And some, quite frankly, we could sit back and say, well, gosh, it's only been 2 weeks. However, that wasn't their reality. And so we had to engage in those circumstances, understand their predicament, if you will, and then identify how we could get their claims moved as fast as possible. And so one of the tactics we did use, quite frankly, in those priority scenarios is we kind of reached in, prioritized that practice as claims, if you will, and had them escalated and processed ahead of the batch in some circumstances to get that out the door as quickly. So we don't cut hard checks. It's not a tactic we utilize. I know it was discussed earlier today, and partially because of our experience here in the state, we really should be past that for us. We're not in implementation mode fundamentally. However, we did have to take some unique steps with some providers to help them get through that aspect there fundamentally. And we'll continue to do that in the next couple of weeks as this rounds out and stabilizes. We will continue to drive on that component there. But claim volumes, turnaround times, and payments is an everyday, several times a day statistic that we monitor, quite frankly. We're always watching it. We're monitoring it by provider type. Quite frankly, we monitor it based on feedback we receive from you. My goal is to not have to receive that feedback from this committee. That's absolutely the goal. But there are RFIs from time to time, and as you can see, sometimes we're able to articulate where, maybe it's not as it seems, and there could be some other contributing factors here. And sometimes it is, no, it's 7 days slower than it used to be, so what can we do to get that sped up and moved out the door? So very, very transparent and aware of that situation, and very, very focused organizationally on continuing to drive that piece down. I think the other key component that has led to some of the claim challenges we've had, specifically to the 90 days, very specific to the transition. These issues did not exist before July 1st fundamentally, and that is the uniqueness of the continuity of care provisions that we utilized here. They were right, honoring existing prior authorizations. But there was also another very nuanced piece of criteria we had to apply, and that was if United Healthcare didn't require prior authorized service, we wouldn't for 90 days either. And that's a fantastic transition item. Operationally and tactically, 100% customized and manual work effort. And so we had to build processes around that requirement to make that work as seamlessly as possible. However, we did build contingencies to counteract for any potential claim errors in there. And so we have processes that run every single week to say, okay, this is what was built to do it. Did anything fall out? Was anything not caught there? Was something missed fundamentally? And then how can we get that claim corrected before the provider receives a denial, before it even exits the building? That's what we're trying to push to fundamentally when we talk to about getting to that claim component. Now, how do we make sure providers don't feel it? Our ability to intervene on it and catch that defect before it even goes out the door, obviously would be seamless to a provider in that scenario when that happens. And obviously we haven't done that perfectly for the last 65, 75 days here. But certainly is our intention fundamentally. Those processes that we built to identify any potential fallout will continue to run for the next couple of weeks while we round out the continuity of care provisions. And then quite frankly for another 5 months, because we have 180 days of timely filing. And so any historical claims that may come in after the fact will stay very laser focused there. We do fully believe that within the next 2 weeks, that volume of noise around claims is going to settle pretty quickly for Amerigroup fundamentally, if you will. And the last item from a claim standpoint I do want to talk about, and this was very, very, very unfortunate timing. It happened right before the transition. We had a system modification that was done that negatively impacted our B3, BHIS, and HAP providers. Could not have been worse, poorly timed. However, it was identified quickly, communicated as such to the IME, so they were aware of that issue, worked very, very aggressively to address both the system correction and the claims payment issues. And I can say to the committee that through the end of August, we're about 99% done with any claim impact. So most of this is in the rearview mirror, but I do want to present it to the committee because it was a challenge we faced during this transition period, one that shouldn't happen, and we're going to put measures in place to make sure it does not happen again in the future. So turning away from the claims component for a minute, again, just want to emphasize, and we talked about providers here quite a bit. We also had, obviously, maybe it doesn't need to be stated, but many member-specific things we had to work through, especially for membership that was new to us. Quite frankly, you can get a care plan, you can get a prior authorization, you can see what a member was receiving historically, but it's the engagement aspect that helps you understand where that member is, what their needs are, what changes might have to occur fundamentally moving forward. And so there was a lot of very individual member-specific activities that did occur. The team did a very fantastic job with those, and very, very happy with what some of those are. And we think in context of the bigger issues, if you will, I'll share one item here. Fundamentally, one of the very first issues we had to resolve, and Director Randol used an example earlier, we had a member that transitioned and just got caught towards the end of June where they needed to have a new floor in their home, fundamentally. And the off got done. It was just as United was about to wrap up, if you will, and then it kind of transitioned over, but it had been out there for a bit. The member had needed this for a while. And so I know it may sound a bit odd to the committee. I'm talking about installing vinyl flooring in my members' homes. We do that. That's a service that is covered in this program, and we have to meet. And so just an example of one of the more unique scenarios we had to tackle right away as the new membership transitioned over effective July 1st. If I could turn through to the next focus here, and then we're going to get to some of what I was biting my tongue on in the last session, if you will. Through all the transition and all the activities that occurred, we didn't take our eye off the innovation ball. We kept everything moving. We could possibly keep moving at the same exact time. There was some balancing but going on there as well, obviously. So I would like to share with the committee an update on a few of those items, and apologize for looking at my watch, but Representative Fry, I want to be respectful of time here. Social drivers of health, or social determinants of health. We actually have a health plan-wide work group and committee formed right now to identify opportunities in social determinants of health, focusing right now at this point in time and identifying pilots. Quite frankly, where do we have a willing partner? Where do we have a tremendous opportunity? And how do we just start? How do we just jump in and get something going? Very focused on food insecurity, employment, stable housing at this point in time. And to that end, and this will be a little bit of a cliffhanger. I will apologize to the committee ahead of time, but we'll have more information on this coming out publicly very soon. We are about to launch a pilot with Monroe Elementary School right here in Des Moines. It's called our CHAMP pilot. Showcases fundamentally our integrated case management capabilities. It truly is a first of its kind partnership with a public elementary school, and really focuses on that school being the community hub around which outreach is centered. The pilot will be primarily focused on housing out of the gate. However, we know that as we get in and engage, that information is going to come to the forefront, and we're going to say, okay, we have a food insecurity challenge here we can work on. How do we make those connections from an integration standpoint, etc. We're very, very excited about this one. There will be more information coming out on this more in depth here in the very, very near future. And then another example is partnership with Iowa Voc Rehab, Iowa Works, focused on one-year apprenticeship training programs for participants and members that have barriers to employment opportunities. From an innovative standpoint, focused on a reentry coordination pilot for individuals exiting incarceration to help bridge their access and provide health and social needs.
Glad you're back.
Wrong direction. That's right. And we actually completed that pilot with 166 members already at this point in time for transitioning incarcerated members, if you will. Opioid risk predictor models, identifying high-risk members for intensive care, Representative Forbes back to the pharmaceutical component, monitoring utilization of very, very specifically opioids, and identifying those members and flagging them for intensive case management. And so if we see a pattern of utilization for opioids, making sure they're in the right case management program so they can be addressed appropriately. And then finally, our certified peer support and wellness and recovery specialists, access to all of our members. So to sum up all that content in detail, very, very intentional about keeping the ball moving, because you can't slow down once you start fundamentally. And I also want to demonstrate the variety of items we're focused on. And hopefully the committee can see we haven't boxed any of that in because we're still learning. And we'll continue to learn as we engage in each one of these. More opportunities will be identified that we can focus on from a social determinant standpoint. Lastly, two items here. Representative Fry, am I good on time, or I need to step it up?
Yes, real quick, but if you could go real quick, then we'll move on.
Perfect. Two very quickly. First, making sure the committee has awareness that on October 1st, Amerigroup is actually transitioning to a new pharmacy benefits manager that is Ingenio RX. It is an Anthem-owned program and offering, if you will. Implementation has been ongoing for several months. Multiple notifications have gone out to providers, multiple notifications have gone out to members to make sure they're prepared. I think the most salient fact here, one of the most critical factors I should say, is from a pharmacy network standpoint, our network is actually larger than it was before with Express Scripts. We beat that out by about 250 pharmacies. At this point in time, only 11 Iowa-based pharmacies are not in our network yet that were before, and we work closely with them to get them engaged and get them to enroll, and I've actually worked with the Iowa Pharmacy Association to help engage with those pharmaceutical members as well. So very, very excited about that. It's going to bring a lot of opportunities, and I suspect that the next committee meeting, if you will have outcomes to focus on there. And last, but absolutely certainly not least, I want to take this opportunity to address a very upfront and time-sensitive item regarding a prior authorization policy that we recently announced to our therapy providers, outpatient therapy providers, for some very, very specific services. Fundamentally, from a prior authorization standpoint, we do believe that it is one of the tools we have at our disposal to help us ensure we stay engaged and can protect both the safety of our members and ensure that all the appropriate services are being utilized, and if not, making sure those services can be identified. It's one of the reasons we prior auth items fundamentally. However, for this policy, the message is play phone tag. We've heard the feedback, and it's clear to us there is some confusion about what this policy is, how it would work. One of the confusions is we've already been counting the time. No, we would start counting up to 24 visits. There's concern about, well, once we hit the 25th visit, do we have to auth it for every single visit? The answer is going to be absolutely not. It would be batch authorizations. I wouldn't want to have to auth every single one of those. But the key point I want to make is we've heard the feedback. We understand the concern. We're going to take a slight pause on this. We're going to review the policy, engage a little bit differently, and fundamentally identify when the appropriate time is to do this with the appropriate measures. So I will yield the floor for questions and answers.
Thank you. We are out of time. We're going to have to move to the next. Thank you for that very last piece. That is certainly something that obviously has been at my desk, and I'm getting a lot of feedback, so I appreciate the update, and look forward to continuing to walk through that with you. So thank you. We're going to transition to Iowa Total Care because of the timing of where we're at right now. And I would like to bring to the table Mitch Wasden, President and CEO of Iowa Total Care. We're glad to have you for your first appearance before this committee.
Thank you.
And we're not overly vicious usually. Just don't make us mad. You have the floor. Thank you, sir, for being here.
Yeah, thank you. Good morning. My name is Mitch Wasden. I'm the plan president for Iowa Total Care, and I'm excited to be here on behalf of our plan to present to the Health Policy Oversight Committee. As you know, we're the new plan in the state, and so part of what our focus has been over this last year is getting the plan up and running, planning for staff and space, and in some ways just making sure the plumbing all works for the new plan. And so my background is I come from 20 years of experience running hospitals and health systems. I've worked at academic medical centers and safety net hospitals. And several of the organizations that I've worked in the past have actually been what are called integrated delivery systems, systems that have a hospital, a medical group, and a health plan all under one roof. And so I think this is an exciting time to be in the state of Iowa, because what I've seen professionally is the power that can come from when you integrate and collaborate with a payer and with the hospital and providers. And part of that is generally, and Sarah Dixon and Jeff said it very well, that sometimes on the provider side, or when I was on the provider side, I would have some of the data, but not all of the data that I would need to do true population health on members. And so by collaborating with the health plan side, which has claims data, which has lots of data that maybe the provider can't see, you actually can leverage the strengths of both of those members, both of those parties on behalf of the member. And so I'm excited as we start this next round of innovation in value-based care, in high-quality value-based care, to be working with providers to say, how do we build the right incentives? How do we build the right data? One of the things that you generally find that has been difficult innovating in value-based care is we provide providers and plans lots of data, but very little answers. And so, Sarah's point was around having timely and accurate information. Some of the challenge is how do we partner as a plan with providers to give them just what they need to make care decisions and make sure that that's timely and accurate. So one of the things that I want the committee to know is that our team is very focused and committed to be a positive change agent here in the state of Iowa. Through a local focus and national expertise, we think we have a lot to offer. We are part of a larger organization that is one of the largest Medicaid providers and state providers in the country, Centene. And we're working hard to create an open, transparent, and collaborative relationship with providers and members in the state. So when we were first awarded the bid here in Iowa, we were very excited. This was going to be one of the largest launches that Centene had done in their history. So Iowa got a lot of focus and got a lot of resource. Initially, we thought we would need 500 local staff, and then the United announcement came. And very quickly, I think I had been here 3 weeks, and the United announcement came, and Amerigroup and Iowa Total Care had to do some shifting of planning and resources. We knew then that we would actually need a second location for our call center. We would have to go from 500 employees to 820. And so that required lots of training. That required thousands of interviews that we needed to get done quickly. And I'm proud to say that today we are staffed and we are operating effectively as a plan. We have worked hand in hand with IME. They have been an excellent guide, given us great oversight as well as suggestions about how to be successful in Iowa, and I feel like we've taken those things to heart. Some of the recent success stories that we've had, and I think this is why we all do this and are in this industry, is that just in the last couple of months, we've seen things like members reach out that want to get out of their nursing home that they've been in for 120 days and want to transition back to their normal home. And we've been able to reach out with those members and set up CDAC services so that they can live independently. We've also had recently a member who would never leave their home because they were afraid of falling, and they were resistant to having a personal emergency response device, but their care manager explained to them how that would work and why that would be a benefit to them. And that member now uses that device and is not homebound anymore. These are examples that we see every day. They're exciting because they do show the complementary nature of a payer that can often have a public health focus in partnering with providers as well. As often happens with a brand new plan, we've been in operation less than 90 days. We have some very good metrics to show for that. But we've got some other opportunities that we need to improve. So, for example, when it comes to claims payment, we have paid 99.8% of claims within 30 days. But part of the challenge when you're a new plan is you're loading thousands of contracts, and you've got tens of thousands of providers that are getting loaded. And sometimes the setup of that system can create issues or unintended errors. And so we've been working very closely with providers to ensure that if we've ever had an error in processing their claims due to a setup issue, that we're reaching out to make sure that if a hardship payment needs to be made, that we can do that. Fortunately, even with some of those issues, we're still getting the claims paid within 99.8% within the 30 days. But we have made over $2.5 million in hardship payments to over 91 providers, many of those CDAC providers, and we're trying to make sure that we're doing the right thing and keeping providers in a safe place. In terms of the remediations to a lot of these claims issues, we have a really wonderful team from our corporate offices in St. Louis who are on site full-time for the next several weeks, identifying issues, putting in remediations, and to date, we have remediated 60% of the known issues in our startup claim situation, and the remaining 40% will be remediated in early October. And so we're moving very fast and taking that very seriously. So some other metrics as we start up, our membership is currently at 262,000 members. We've got network adequacy across the entire state with 37,000 providers or practitioners in our network. We do have one area that Director Randol commented on for elderly waiver in one part of the state that is not at 90 or 75% network adequacy. They're still at 68, and we continue to work to close that gap. In terms of provider services, we have so far for member services taken 54,000 calls with a speed to answer time in 6 seconds. And then provider calls, we've taken 23,000 calls with an average speed to answer of 16 seconds. And we are well above the standards for taking phone calls. In terms of claims paid, we've paid over $160 million of medical claims and processed $500,000 of those claims. And for pharmacy, we have processed over 680,000 pharmacy claims for a total of $52 million. With LTSS, we have a really wonderful group of LTSS staff that work with us every day. They've completed over 2,300 level of care assessments. We've committed to members during this transition, as there was a large influx of these assessments to be done, that their care plan will not change, even if it takes them longer to get that assessment done, so that they continue to receive services. Another thing that we have made quite a bit of progress in is the health risk assessments, of which the social determinants of health 13 questions is a part of. And we have completed over 30,000 assessments. To do that, we have made over 312,000 phone calls out to members to try to get these assessments done. And just to show you the power of these kind of assessments, we recently had a member who had several behavioral health and substance abuse disorder diagnoses, who was homeless and had agreed to care management, but was never answering their phone. Our member outreach group finally did get a hold of her, set up a in-person meeting, and was able to use one of the health risk assessments. From that assessment, they were able to connect them with a behavioral health provider where they could actually get medications filled, because this particular member had not gone to a doctor in 12 months. And so after that was done, we set up this particular member with a primary care physician and scheduled a wellness check-in. And so these are the kinds of things that when we talk about this partnership with payers as more of a public health focus than providers, I feel like really shows some of the value of these population health initiatives. In terms of transportation, which is really key for the Medicaid population, we have facilitated over 107,000 trips to medical appointments. About 70,000 of those are non-emergent medical transportation, and 37,000 are waiver patients. Another great story here, we had a member who did not realize that transportation was part of the Medicaid program. As a result, he had a chronic condition and was failing to go to medical appointments or even set up medical appointments. Our case manager reached out to him and let him know that this actually was a benefit and it was something that we can actually help arrange. This provider was also given a list of specialists who could address his chronic illness, and now this provider is going to his regularly scheduled appointments and using the transportation benefit. One of the things that I would like to do as I conclude my remarks is just to let you know that our team of 820 Iowans here, taking care of Iowans, is 100% committed to being the best partner with members and with the state and with providers that we can be. I can tell you that with any startup, they have all been working very, very long hours, but they are honestly excited to be here. They are honestly excited every time they hear good feedback. Obviously, they are devastated when they hear bad feedback, but we know we need to hear it because part of the success of a long-term relationship with any MCO is basically having that dialogue and having that feedback. And so I'm grateful for the chance to be here with the committee and take any questions as to how we can improve and become better. So at this time, if there's any questions, I'd be happy to take those.
Thank you, Mitch. We want to welcome you to Iowa and appreciate your work here. Look forward to getting to know you more and better in your organization more.